just the left side. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. Epic CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly, to better assess overall cardiac function of patients in an everyday setting. Epic CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. Epic CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips Epic CVX. Innovation and you, Philips.
This thing in front so that anybody who's trying to walk,
You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You need to assess the function of the whole heart of patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. Epic CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. Epic CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. Epic CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips Epic CVX.
7,000 लोग आने वाले साउथ अमेरिका से पता नहीं यार.
Innovation and you, Philips. You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. Epic CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. Epic CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. Epic CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips Epic CVX. Innovation and you, Philips. Exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. Epic CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly to better assess overall cardiac function of patients in an everyday setting. Epic CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. Epic CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips Epic CVX. Innovation and you, Philips.
Hi, am I audible?
Can you see me and hear me? Can you hear me and see me?
Hi, Vinayak.
Hi.
Yeah, hi. So I'm just going to start welcoming everyone, right? And then over to you.
No problem.
Perfect. Okay, so I think, right, I can see you, Vinayak.
Yeah.
Can I can you get my screen? Make my video started. Hi. Good evening, everyone. I'm Dr. Shantanu Sengupta, and soon Dr. Mahesh Fulwani will be joining me to this Echo Nagpur virtual meeting. This is the 16th annual meeting we are doing it, and this and the first virtual meeting. And as you can see, this is because of this pandemic situation, and we have a host of faculties which are going to be an amazing clinical discussion. So we start on Saturday, that is today, at 4 o'clock, and we'll be ending till 8 o'clock, 8:30 today. And again on Sunday, it is going to be from 4 o'clock to 8:30. Now, this is the platform we're using, where it is going to be on a Zoom platform, but the whole relay is on the YouTube. So at the end of the talk, if you have any questions, please feel free to send us a message as a chat, and I will be sharing it with the faculties. So we have our first speaker, that is Vinayak Agrawal, who has already joined us from Delhi, and he's going to speak on mitral annular calcification, nuts and bolts. It's a very important topic. Vinayak is hi, Vinayak.
Hi.
Nice to see you. So you're all set?
Yeah.
Yeah. So Vinayak is a great clinician, and he's going to run us through Echocardiographic MAC, a very important topic, and we have started understanding it of late. So over to you, Vinayak. Can you say
Thank
this?
you.
Yeah. You can share the screen. Perfect.
Am I seeing?
Yeah, you're there. You can start.
Thank you, Dr. Shantanu, for inviting me to this very, very prestigious Echo Nagpur, and I'm very happy to be part of it. And of course, the opening batsman to it as well. And I think it's apt to start it with a topic which is mitral annular calcification, which is something which we see very often, but don't really give it too much of thought about its diagnosis, its prognosis, and of course the management part. So I'm going to touch upon in the next 15 to 20 minutes about all the aspects in brief. We all know that mitral stenosis, the etiology in almost 99% of the patients that we see is rheumatic heart disease. But of course, there are other causes which we keep seeing, like the congenital MS, carcinoid heart disease, which is mostly on the right side, but if there is a large secretion of the 5-HT, then it can affect the left side as well. Radiation-induced mitral valve affection, mitral annular calcification, which is what I'm going to be talking about, methysargite, and in, of course, cases of SLE. Now, we all know about rheumatic heart disease. All of us have seen it. I'm not going to go into the details. But just mentioning grossly, what we see is the tips of the mitral valve leaflets are involved. They are thickened. They may be calcified in later cases. And there is a commissural fusion, which is very, very important for diagnosing, which is what gives the dome shape to the mitral valve. And there is a restricted movement of the PML, and this is a fish mouth appearance of the rheumatic MS with very highly thickened affection of the subvalvular apparatus as well. Now, if we look at the mitral stenosis, classically we look at this dome-shaped mitral valve with restricted PML. The AML is domed shape. Most of the times you would also find in a lot of cases rheumatic involvement of the aortic valve and the tricuspid valve. And this is a very, very classical picture of a rheumatic heart disease. And when you look at the planimetered area of the valves, you can see the commissural fusion, which is characteristic of rheumatic heart disease. And this is something which we all should be, which we all look at, because at the time of BMV, these are important issues to look at. And of course, the subvalvular apparatus being very, very important, that it should be, if it is severely thickened or tubular in nature in terms of its involvement, then it gives its a contraindication to BMV in some of the cases. And this is a classical rheumatic heart disease, rheumatic valve, mitral stenosis, which fish mouth appearance, commissural fusion. This is the LV view, this is the LA view, and you can see a lot of thickened body. So I'm beginning this to tell you that, okay, this is what we see in a case of mitral stenosis most often, which is the quintessential rheumatic mitral stenosis. And this is how we look at it. This is a patient who has a thrombus in it and high gradients across the mitral valve. A lot of times you may also pick up associated valve disease and tricuspid stenosis. So you have tricuspid stenosis as well as MS, again part of rheumatic heart disease. You can also have parachute mitral valve in some cases where you have a single papillary muscle, the valve opening is restricted, and these also are seen mostly in childhood but can be seen in adulthood. Coming on to another variation, which is a radiation-associated cardiac disease. Here, because of the radiation in the past, after many years, the patient may present with conduction system disease, pericardial CCP, vasculopathy or macrovascular disease, and non-ischemic myocardial fibrosis, but also valvular heart disease, where if you look at this valve, the anterior AML is actually significantly affected along with the aortomitral curtain, which is characteristic of the radiation-associated disease. And this is another case of radiation-associated MAC. You can see this Y-shaped aortomitral curtain. This is courtesy Dr. Nitin Gurkale, who lent me this case. And you can see this classical Y-shaped thickening calcification of the aortomitral curtain with significant mitral regurgitation, which may mimic a classical MAC, or mitral annular calcification, or degenerative mitral stenosis. And this is in a nutshell, which I want to tell you about the difference between rheumatic MS, degenerative MS, which is mitral annular calcification, and of course, the radiation-induced mitral stenosis. So as I've mentioned that in rheumatic, I'm not going to touch on it. The radiation mostly affects the AML and the aortomitral curtain. Commissures are rarely fused. And then we will discuss the degenerative mitral stenosis along with mitral annular calcification in the next few slides. So with that background, I come to the topic today, which is the mitral annular calcification. Now, it is a degenerative process which leads to this mitral annular calcification and affects about 9% of women and 3% of men. So it's more common in women and more in the elderly advanced age of more than 60 years. Those who have multiple risk factors like hypertension, diabetes, coronary artery disease, basically atherosclerotic milieu. And a specific subset is the chronic kidney disease, or CKD, which involves these patients at a much younger age. So you can actually pick up mitral annular calcification as early as 25, 30 years in a patient of CKD on dialysis. We see that very often. And in fact, if you look at the end-stage renal disease, 40% of such patients will have mitral annular calcification, or MAC, on echo. Now, the mechanism of mitral annular calcification also needs some emphasis, because there have been multiple etiologies which have been proposed, like abnormalities of calcium and phosphate metabolism, increased hemodynamic stress, and atherosclerosis. There is a very interesting study which was published recently in Circulation Cardiovascular Imaging, where when you look at the CT MAC, and if you do a FDG PET activity and you see them over a period of 2 years. So this is a case of 3 patients, one with the mild disease, calcium score For moderate disease, the calcium score is about, 5,000 or so, and this is a severe calcific disease. And if you do the FDG PET in these cases, you can see in this number one patient, it is not much. The activity in the second one is moderate, and in the third one, it is significant FDG uptake on PET you can see in the third patient. And when you follow them over 2 years, you actually see a lot of calcification at those points of inflammation. So the de novo areas of MAC that developed at the site of intense F fluoride uptake in the lateral annulus eventually went on to develop significant MAC, and hence the impression is that there is a self-perpetuating cycle of calcification and inflammation which goes on to produce mitral annular calcification. If we look at the clinical studies, the best would be Framingham heart study, where 16 years follow-up in about 1,200 patients. We looked at MAC, and it was associated with increased cardiovascular risk events with hazard ratio 1.5, CV death hazard ratio 1.6, and also increased all-cause death. So it is a marker of increased atherosclerosis and higher cardiovascular death and events. So it has been seen that with each 1 millimeter increase in the size of MAC, 10% increase in CV events, death, and all-cause mortality happens. So this is a very important prognostic marker which we should not ignore. There are also other studies as recent as in 2016 where they've seen that in about 1,000 patients with degenerative mitral stenosis, the 1 and 5 year mortality or survival rate, were about 78% and 47%. So in 5 years' time, patients with degenerative mitral stenosis, where the hallmark is MAC, only 50% survival has been seen. Now, there is another study when you look at patients of aortic stenosis, this was a study published in 2016, and they've seen that in patients with more than 65 years of age, a non-contrast CT imaging in aortic stenosis patients saw that isolated posterior annular involvement in MAC was 33%, anterior annulus involvement was much less at 5%, and both location was seen in about 10 to 11% of patients. Hence, in patients who have anterior annular involvement in MAC, actually predict smaller mitral valve area eventually compared to the only posterior involvement of the annulus with MAC. Now, how do you diagnose MAC? There are various, if you go systematically, you first look at qualitative data, which is your visual appearance, calcification, thickening, leaflet mobility, and the adequacy of coaptation. The quantitatively, you can go into measuring the mitral valve area, gradients, and indices of associated mitral regurgitation. And we will discuss that. And you have to correlate whatever you see in patients like these with the clinical data, and you should see whether it fits into your scheme of things. Now, if you look at how to quantify the severity of MAC, it is expressed as the maximal thickness in millimeters measured from the leading anterior to the trailing posterior edge at its greatest width. If the calcification is between 1 millimeter to 4 millimeter, it is mild to moderate. If it is more than 4 millimeter, it is severe MAC. This should be more than 1 millimeter. And if, like for the example, in this case, if you look at the MAC here, the maximum maximum length of the calcification is 1.22 centimeters. So it is more than 4 millimeter. It is severe mitral annular calcification. The other clues can be in fluoroscopy. In LO projection, you can see there is significant MAC on fluoroscopy. And of course, CT, which is wonderful for picking up MAC, shows a significant mitral annular calcification in the posterior side, some on the anterior side as well. There has been a proposition of a classification for MAC into mild, moderate, or severe variety based on how much is the quantum of the MAC which is surrounding the annulus. So if there is a focal soft echo density of the mitral annulus with less than 180 degrees of total annular circumference involvement, it is mild. If it is more prominent echo density, so it is relatively subjective, but it covers less than 270 degrees of total annular circumference. So half, 2/3, and more than 2/3. So if it is more than 2/3 of the total annulus with marked echo density, it is suggestive of severe MAC with, of course, the thickness that I've already mentioned. The most characteristic feature of MAC is that it affects the posterior mitral annulus. The calcium deposition occurs between the posterior LV wall and the PML, and the anterior mitral involvement, annular involvement is much less and is sign of advanced disease. So here is an example of a patient who has leaflet calcification, but the annulus is significantly calcified in the posterior. So this is the aortic valve, which is thickened again. There is some calcification seen even on a chest X-ray, where you can see the posterior mitral annulus is involved, and which is proven by the CT in a very nice depiction. Coming to the echo features, so this is a case which I saw recently, and you can see there is a significant mitral annular calcification. The leaflets, you can see that the calcification is growing from the base, and the mitral tips, leaflet tips are still free a little bit. So this is a hallmark of mitral annular calcification, where the tips are spared, which are characteristically involved in rheumatic heart disease. And there is significant mitral regurgitation. Now, I'm going to touch upon this when in a later slide. But please remember, because of acoustic shadowing, because of the calcium, significant calcium, you may miss out on the mitral regurgitation in these cases. So you have to be aware of that. And here is another view. You can see significant aortic calcification as well. There is the aortic sclerosis. There is a significant mitral stenosis because there is hardly any opening of the mitral valve. Look at the thickening of the mitral annulus and the leaflets, where the calcium has encroached upon the leaflets. There is also a sign that there may be some involvement or thickening of the posterior wall, as well as some septal involvement in these cases. And this is a 3D picture. You can see all around, this is aorta, so this is the AML, and this is the PML. All this is calcium, significant calcification of the annulus. And you can see from the LV side, there is significant involvement of the annulus all around. Now, when you estimate MVA, we estimate it exactly the same way as we do it for rheumatic heart disease, rheumatic mitral stenosis, based on planimetry, continuity equation, PISA, and pressure half-time methodology. Now, when we look at the transvalvular gradients in a case of severe MS, more than 10 millimeter of mercury mean pressures signifies severe, with a valve area of less than 1.5 is now considered severe MS in terms of functionality, and less than 1 centimeter is now considered very severe MS. But in terms of echo parameters, we will take this as less than 1 centimeter square with evidence of pulmonary hypertension. The only problem with pressure gradients is that they're highly dependent on heart rate and cardiac output, and also the fact that if in a lot of these patients of MAC, they have high LVDP because of hypertension, LVH, they have stiff ventricles, so the gradients may be misleading in terms of the severity. So they're not reliable in assessing severity, but they will be helpful in a clinical decision making. So for example, if the patient has features of HFpEF, heart failure with preserved ejection fraction, you have a significant MAC, the patient is severely dyspneic, and you're getting a gradient of mean gradient across the mitral valve of 15 or 18, you know that there is significant mitral stenosis because of MAC. Planimetry is relatively flow independent and load independent, and hence it is a good method in these cases. The problem is that in rheumatic heart disease, it's the tip which are involved. So you can go into the LV, look at the tips, and measure the planimeter area very well. But in the case of mitral annular calcification, it is the annulus. So a 2D image will not be able to give you a very good idea about the severity when you go by planimetry. 3D may actually help you in these cases. So in this case, if you look at the planimetry from the LV and the LA side, you have to actually know the narrowest portion will be somewhere around the annulus and not at the tips. But do see that the commissures are open in MAC as compared to the comparative in rheumatic heart disease. So pressure half time is another valuable method of assessing mitral valve area. In rheumatic heart disease, it is validated by 220 divided by pressure half time. And the strength is that it is feasible even in distorted mitral leaflets. But what about in cases of, say, degenerative MS? Again, the problem is that in rheumatic versus degenerative MS, there is a geometrical differences. As I said, in rheumatic heart disease, it is a dome-shaped appearance because of the commissural fusion, while in the case of DMS, it is more like a tunnel shape because of the annular involvement. So because of the abnormal LV and LA pressure physiology, and due to advanced age, diastolic dysfunction, CKD, diabetes, etc., in these cases, we see a lot of abnormality can happen. The overestimation of the mitral valve area can come in, as was seen in a study by Chu et al. In 2008. Continuity equation is still valid in cases of degenerative MS. And the limitations is that if there is an associated MR or AR, it may lead to over or underestimation of the area. So in a case of DMS, we do recommend mitral valve area to be determined by continuity equation. But if there is significant MR or AR, then this is not something which we can use. PISA again is something which can be useful in some cases, but technically challenging, and it may be subject to measurement errors, and there are no validation studies in DMS with PISA. So there is an option which is real-time 3D, and it improves the ability to finding the plane with the narrowest mitral valve area, which is at the annulus. And this was again shown by the Chu et al., where they measured the 3D mitral valve area, and it was actually correlated better with the continuity equation than which was measured with pressure half time. And there were no significant differences between mitral valve area by real-time 3D and by continuity equation. And so the only thing is that it is technically challenging. You need a very good data set to come out with this. This is, you can see that in this, the typically tunnel-shaped geometry is there and affects the base of the mitral leaflets rather than the tips. Very important thing which I want to mention here is the assessment of mitral agitation in the cases of MAC. As I've already mentioned, that there is a presence of acoustic shadowing in LA, you may miss out on mitral regurgitation. So a blind continuous wave sweep of the LA may detect the signature mitral regurgitation spectrum with high velocities, and imaging of the LA dome in plaques actually will take away the calcium or acoustic shadowing and may actually show you the mitral regurgitation severity. T is invaluable in such cases because it gives you an on-fast view of the mitral valve from the LV as well as the LA side. You can pick up significant number of jets and also pick up actually functional or non-functional cleft-like indentations in the mitral valve, which are very important when you're deciding what to do with these patients. The PISA method can be used for quantification of MR in such cases, but it has its own pitfalls, which we should know. Another important issue is the diastolic dysfunction in MAC, which is confounded due to associated hypertensive heart disease, aortic stenosis, CAD, CKD, elderly patients. And in cases of severe MAC, mitral orifice area is decreased, which leads to increased diastolic transmitral E velocities, while the lateral E velocities are decreased because of restricted PML excursion. Hence, there is an inherent E by E prime ratio is increased and will tell you that there is significant LV dysfunction. So we don't really know how to specifically determine diastolic dysfunction in these cases and have to rely on functional data. Now, last few slides, I'm going to just touch upon casioma, which is, you can see an exuberant calcium deposition at the base of the PML and in the annulus. You can see significant mitral regurgitation in these cases, severe mitral regurgitation, and significant casioma. This is a exuberant calcification, which you've seen in some of the cases. And you can see this is the casioma here, very significantly seen in such a case, and with significant pulmonary hypertension as well. So it is a rare variant seen in about 0.6% of patients with MAC, and more seen in elderly women with history of hypertension, CKD, and dyslipidemia. This caseous MAC has a toothpaste-like texture and is surrounded by a non-collapsible calcific envelope. And it may be associated with atherosclerosis, and the etiology may be an altered calcium phosphate metabolism. Now, I'll just touch upon the role of cardiac CT, which complements the echo data because of its higher spatial resolution. It is excellent for detailing the anatomical features of MAC, and its multiplanar formatting helps you in mitral valve and annular anatomy in different projections, and invaluable in pre-procedural planning, as in, like, for example, TOWER, or even in TMVR, because it helps you in, even new anatomy and potential complications can be precisely predicted. And if you look at the cardiac CT in MAC, there was a study in 2016 where they've seen that the MAC was seen in 50% of the patients who were pre-TOWER evaluation. 2% were severe MS, 22% of these patients had less than 1.5 area, and 10% with a moderate MS. And you can see that the extension of calcium to A2 segment of the AML was associated with more severe mitral stenosis. Now, the last slide, I'm going to tell you about the role of in cases of severe calcific MS, surgery has been tried, but has been shown to have not very good results. There is a chance of high mortality in these cases. So hence, valve in MAC TMVR was tried and has been used with dedicated image-based planning. So you have echo, transesophageal echo, CT imaging, 3D reconstruction, and of course the final result, which you can see is pretty much excellent. But the recent studies of 2018 have shown that the outcomes may be good in terms of hemodynamics and symptomatic relief, but there is a 25% mortality at 20 days and 50% mortality at 1 year. There is a role of 3D printing as well in determining the role, whether you can put a device or TMVR in these cases, and it gives you a pretty good idea about MAC and feasibility of LVOT obstruction. Thank you very much.
Thank you, Vinayak, for this excellent presentation. I think you have summed up something very important discussion on MAC and differentiating with rheumatic mitral volume involvement. Now, there are a few questions I can see. So, to simplify, what are the gradients in MAC? I mean, rheumatic, is there any classification of having gradients in MAC causing mitral stenosis?
So I've gone extensively into the literature. I haven't found any specific gradients which have been mentioned for MAC specifically. I think it is safe to say that we can probably use the same gradients as that we use in rheumatic mitral stenosis. The only thing which we have to remember is that the gradients can vary significantly because of the comorbid conditions like CKD, left ventricular hypertrophy. These patients are elderly with comorbidities, so the ventricles are stiff. The gradients tend to be less actually in these cases. So you may underestimate the gradients and the severity of mitral stenosis. So you have to validate it with other modalities, which I have already mentioned,
right? And
then come up with the overall impression.
Yeah. Any role? Second question is, any role of exercise in degenerative mitral stenosis?
Yeah, I think that's a very good question. I haven't added that slide, but yes, if you can subject these patients where you're not sure about the severity of DMS, then you can subject them to exercise stress echoes. And if there is a significant increase in PA pressures or the gradients, then you know that you're looking at as functionally severe degenerative mitral stenosis.
So Vinayak, if I can add Partho, I can see Partho online. Can we have the same question? So can you get Partho? Partho, are you there? Can you unmute him? Hi, Partho. So hi. So before we go to your talk, which is on diastology, how do you grade MAC, degenerative mitral stenosis? Do you have any grading thing at your place? Any updates?
So yeah, well, I mean there are grading for the severity of the MAC. We do mild, moderate, severe, but most of the grading is now relied upon by CT because in the structural heart interventions that are coming in, echo is very good for the hemodynamic grading of the stenosis. So we go more for the hemodynamic grading of the gradient and the severity of the stenosis, and the structural grading of the amount of MAC is done on CT.
So one more question for Vinayak: Is surgery does surgery has a good outcome in MAC?
No, it doesn't. In fact, most of these patients, the surgical risk is prohibitively high. In most of, see what happens is that there are case series which I did not show, but the most of these case series show that there are surgical techniques which can take out the calcium. You can use various techniques to debride that mitral valve and the annulus. You can even use patch technique to mend the annulus and then place a new valve there. But overall, you have to remember that these are sick patients with multiple comorbidities. And even mitral valve replacement may not change the course of the longevity of the patient or the mortality. Or these patients may show a very high mortality post-operatively in these cases. So that is why TMVR came in. And that also has shown almost 50% mortality at 1 year.
Right.
So we have limited options. A lot of patients are actually left on symptomatic treatment and not pushed into either surgery or TMVR. But these are the two options which are available to you.
So can I just quickly add to that? I mean, I know that we are running out of time. So first of all, surgery, trying to do anything with the MAC is a nightmare. If you try to, the surgeon, the last thing they want to touch is the annular calcification, because if the annulus comes out,
you're gone.
Death on the table. You cannot do anything to that. And it will typically rip off the entire AV junction, and that's a death on the table. So surgeons are scared of doing anything to the annulus. Most of the procedures that are developing is, while the annulus is calcified, how can we take care of the luminal stenosis? And for that, there was balloon expandable approaches that have been tried, but they have not been very successful because of a lot of paravalvular regurgitation that happens. So a valve in MAC, balloon expandable, typically does not conform because the geometry varies from patient to patient. So that's a problem. But there is currently a trial going on with tendine valve, and we are participating in that, in which we are able to place some of the surgically guided. So it's basically you do a transapical approach and place a valve inside the MAC, and that has shown some benefit. It's currently, the enrollment is on, and we await the results of the trial. Sometimes surgeons have attempted to do directly a valve placement under direct guidance without really doing anything to the MAC. So they will just go ahead and expand a valve and try to close off any paravalvular regions. But these are difficult cases. And if the patient has lots of comorbidities and the life expectancy is not very good, less than 1 year, then typically it is medically managed. So as correctly Vinayak pointed out.
Perfect, Vinayak. Excellent presentation. We have a couple of questions. I hope you continue, but I think one question which has come up, I think which Partho can continue in the diastology, is that E by E prime in MAC, is it possible? So I think let Partho continue with his talk. And Partho Sengupta, he's my elder brother. He's professor at West Virginia University in Morgantown and chief of cardiovascular imaging over there. Partho, welcome to you. And he's going to speak on diastolic dysfunction, a very important topic. Partho, you can share your slides.
Will do. Thank you very much for having me here, Shantanu. And good morning. I can see Sunil joining from Mayo Clinic Sunil. Also. Good morning, Sunil. And good morning, good evening, good afternoon to all the viewers wherever you are. So I'm going to just try to share my screen and get my slides going. Shantanu asked me to do something which is practically impossible. I think the topic itself, are you able to see my screen?
Yeah. Yes.
Okay, good. So the title is, how do you make diastology easy? The answer is that you really don't have an easy answer to diastology. So I'll try to do something which all my mentors and people from Mayo Clinic and Cleveland Clinic and worldwide they've attempted to do, is to how do you get handle over the diastolic function of a patient. So what I will do is I'll give some general principles. I'll highlight some concepts which are emerging and which are important for us to understand. I'm going to then go quickly to the current guideline recommendations, what are the strengths and what are the pitfalls, and provide some case examples and special situations. So first of all, the question that comes up is, can you measure diastolic function? So this is a question, let's think about it. Can you measure mental depression? Well, is there like a probe or some kind of a mechanism you can directly go and get a measurement of diastolic dysfunction? The answer is no, you cannot. And to just elaborate on that, can you measure mental depression? Is there like a one score or something that you can go to and say that, well, this is a measurement and the patient has mental depression? The answer is no. So mental depression is measured by a congregation of different symptomatology. Same way, diastolic dysfunction is assessed by a congregation of different types of abnormalities that the muscle and the flow and the interaction of the muscle and the flow show us, suggesting the presence of diastolic dysfunction. So in essence, the concept that diastolic dysfunction can be measured is incorrect. Diastolic function cannot be measured. It is a latent or an unseen behavior of the myocardium. And by latent behavior, it means, for example, when you explain gravity, can you see gravity? Can you measure gravity? The answer is no. Newton explained gravity via looking at motion. So you can measure motion. So by measuring a surrogate variable, you can express the presence of a latent state or a condition, and that is diastolic dysfunction. Same way, evolution, when Darwin proposed evolution, he spoke about genes. Genes were not seen by him. They were not measured by him. So the genes were as a latent concept or an unknown behavior. Perhaps in the future, there is something that we can measure directly. But at this moment, diastolic dysfunction is characterized as a latent, unseen behavior of the myocardium that we have to characterize by looking at different variables and how they're traveling together. So when we typically look in diastolic function, the most of the concepts have emerged from our catheterization-based estimation of LV diastolic function behavior. And it is important to characterize that this diastolic function is a combination of active relaxation of the left ventricle. And as the LV contracts, then it comes back, it recoils very quickly, or what is called as the restoring forces that are important for a very quick recovery of the diastolic pressure. And in addition to that, there are structural elements, and which is called as the LV stiffness, that is talking about what is the plasticity, how compliant is the left ventricle. So there is a component of LV stiffness that also contributes to the ability of the left ventricle to receive blood. And the atrium, when it contracts, it encounters this plasticity or the stiffness of the left ventricle. That's the third element that we encounter for understanding diastolic dysfunction. Now, if you would look into the filling pressure, LV filling pressure, you can see different components of filling waves at different phases of cardiac cycle that give us an insight about some of these stories. So you have an LV minimum pressure that comes very quickly just after the isovolumic relaxation. Then you have diastasis related slight plateauing of the pressure, and then you finally have the atrial contraction. So the LV minimum pressure is a combination of active relaxation and restoring forces. And this plateauing, and followed by plateauing, the atrial contraction is an expression of the stiffness of the ventricle. So stiffer the ventricle, more higher the pressure will rise up after the atrial contraction happens. Typically, just before the atrial contraction, there is a point which is called as the LV pre-A pressure. And when we measure pulmonary capillary wedge pressure, when we talk about LA pressure, mean LA pressure, this pre-A pressure is what it correlates best with. So most of our cath reports talk about LV end diastolic pressure, but in fact, it's the LV pre-A pressure that has the best correlation with the mean pulmonary capillary wedge pressure and LA mean pressure. So most of the correlations are typically required to be performed with the LV pre-A pressure. And if you want to know how stiffer the ventricle is, then you can look into the LV and diastolic pressure. So you can have a situation where the LV minimum pressure and the LV pre-A pressures are not elevated, but the LV and diastolic pressure is elevated. And that is because the LV is not having any problems in initial part of the diastole, but the LV is stiffer, and then the LV and diastolic pressure rises up. So that situation is possible. So these fundamental concepts are important when we correlate our echocardiography to what we see on invasive cardiac catheterization. Very early in the diastole, as the LV minimum pressure comes in, it creates a pressure difference between the atrium and the ventricle. And this is the pressure difference in the atrium and the ventricle. And you can see here, this pressure difference is what drives the blood to move. And so there is a suction. There's a rapid sucking of the blood in the very early part of the diastole, which drives the E wave. And then subsequently, when the atrium contracts, you see a second elevation that drives the A wave. So you have the E and the A that is seen on the transmitral Doppler, pulse wave Doppler, is a resultant of all these hemodynamic pressure changes that are happening inside the LV and the left atrium. You also have an ability to get indirect understanding about the transmitral filling pressure differences by looking at the pulmonary venous velocities. And most importantly, you have systolic and the diastolic velocities, but most importantly, the phase which becomes very interesting is the later part of the diastole when the A waves comes in. When the atrium is contracting towards the ventricle, there is a small portion of blood that regurgitates back into the pulmonary vein. So there is a reversal, small reversal of the flow back into the pulmonary vein. This reversal becomes very interesting signal when the LA pressure rises up. When the LA pressure increases, this reversal wave gets much more exaggerated. And that can be a marker of elevated mean left atrial pressure as well. So importantly, you need to also recognize that the filling pressures may be completely normal at rest. And they may be completely changed with exercise. So here is the situation when you rest, you have a pressure difference and the E wave. When you exercise normally, the restoring forces are also rapidly exaggerated. And as a consequence, you can see there, this is a minus pressure that is being developed at the LV, inside the LV cavity, which allows a more transit of the flow in the early part of the diastole, even if the diastole is shortening up as the heart rate is increasing. So this drives the traffic of the blood in the diastole by having an exaggerated influx because of this negative suction, exaggerated suction that develops with exercise. Now, with the heart failure, the pressure waves may be completely normal at rest. However, this ability to generate this mechanism, exaggerated suction, may be completely obliterated, and you will have a rapid increase in the pressures all throughout. So it is important that a resting pressure may not completely communicate the exercise intolerance, and patients may be symptomatic. And therefore, if you have measurements that are performed at rest, and if you're not sure if they correlate with the patient's symptoms or shortness of breath, then you need to consider some form of stress so as to be able to understand if this is diastolic dysfunction or elevation of the filling pressure with exercise. That's what is explaining the mechanisms underlying the patient's symptomatology. So these concepts are important for us to understand as we move forward. Now, just correlate of what I just presented, you see the continuum of diastolic dysfunction. So you can have a stage developing the ventricle that will lead to ultimate heart failure symptoms, but they could be abnormal diastolic variables. Then there could be shortness of breath that may only happen during exertion. So you may need exertion or exercise to uncover the changes. And finally, you will have symptoms that happen only will happen even at rest, and the patient, of course, is presenting with classical features of heart failure. So this continuum of how the LV behaves need to be kept into consideration, and exercise is a very important mechanism that needs to be brought into picture even when we evaluate diastolic dysfunction. The second conundrum that we see currently is that we have heart failure preserved ejection fraction. We have a concept called as diastolic heart failure and diastolic dysfunction. These three concepts are prevalent in the literature, and many patients who have heart failure with preserved ejection fraction typically may not show resting abnormalities in LV parameters to characterize diastolic dysfunction. And therefore, it is important that when you see a distribution in which you're not able to explain the heart failure preserved ejection fraction with the parameters being a normal, try to have exercise incorporated in your clinical regimen so as to be able to get closer to the diagnosis. Nevertheless, there is a continuing conundrum to explain why some of the diastolic function variable do not get recognized in the heart failure with preserved ejection fraction patients. And in this situation, typically the answer is because of the heterogeneity in which it may be not the heart, it may be the system outside the heart, the vascular system, the muscular performance. There may be extra cardiac mechanisms playing to explain the exercise intolerance and shortness of breath. And the heart may be just one of the only bystander in this whole complex milieu of heart failure in which the whole peripheral circuit is failing. And therefore, there are phenotypes where the diastolic dysfunction profile from the myocardium may not look that abnormal, whereas the peripheral circulatory system may look more markedly abnormal. But exercise, of course, should be invoked in order to ensure that you're not missing upon some of the parameters being also clearly explained by just cardiac function status. But this concept is important, that many patients with heart failure may not have diastolic dysfunction variables remarkably abnormal is because of a peripheral circulatory system that is failing along with the skeletal muscular system that explains the shortness of breath. The second thing is that there is nothing called as isolated diastolic dysfunction. Typically, if you look, depending upon the lens and the parameter that you use, you will be able to see some form of systolic dysfunction even in patients with diastolic dysfunction or who are then presenting with diastolic heart failure. So this is a continuous change. Typically, the long axis of the heart responds very closely with the performance of the left ventricle in both systolic and the diastolic dysfunction direction, and therefore there's a continuous change that happens. Now let's come to the clinical recommendations. This is the guideline that was developed. The first thing that is important to recognize that if you have any of these situations, coronary artery disease, pathologic LVH, LV systolic dysfunction, wall motion abnormalities, if you have already established parameters suggesting LV systolic dysfunction like strain is abnormal or S prime is reduced, then you're not questioning whether this is diastolic dysfunction or not. It is assumed that when you have an abnormality of this scale, the patient has diastolic dysfunction. The question comes up when you don't have any abnormality and you're trying to evaluate diastolic function and trying to understand if shortness of breath is because of the heart. And in that situation, you have 4 key parameters that you start off with. So the current guidelines try to make it more simpler for clinical application. You look into the transmitral filling velocities. You try to get the E by E prime ratio, which is an expression of the LA mean pressure. You do the mitral annular velocity, mitral flow velocity, get the E prime, E by E prime, LA volume, and the tricuspid regurgitant velocity, which will also increase as the pulmonary capillary wedge pressure increases. Once you have this 4 parameters and you have the E by E prime, And there is a lot of questions people ask whether it works, it does not work. But to simplify, if you understand that you're using it as a parameter which is more than 14, so you're not going into the gray zone of less than 10 or 10 to 14. You're just taking presence of a extremely abnormal E by E prime that is more than 14. Then you come to this pathway. Out of these 4 parameters, how many are abnormal? If majority are abnormal, and majority means that 3 or all the 4 are abnormal, then you have the patient with diastolic dysfunction. If there are 0 or only 1 parameter, then this is normal diastolic dysfunction. There may be some relaxation abnormality. For example, typically we see E prime may be reduced. Well, everything else is normal. That is a relaxation abnormality. The patient has not yet gone to the stage of diastolic dysfunction. And when there are only 2 positives, then situation is called as indeterminate. Now, this is simplified, but the complexity that arises when you have an indeterminate situation, what should you do? Well, when you have an indeterminate situation, you don't end up the story there. What you typically say that I cannot determine based upon this echo findings, I need more parameters. So if in that situation, you can go for more variables, like you go for pulmonary vein flow structure and you see exaggerated reversal, or if you do an exercise and the patient becomes symptomatic and you're able to see uncoupling of some of these parameters, as these parameters becoming abnormal, then you have clinched. So when it is indeterminate, your story, you don't stop at that point. You ask for more analysis or more information to be obtained. Typically, you will suggest an exercise to be done if you are not very sure about from the echocardiogram to answer the clinical question if this is diastolic dysfunction. So here is a situation where the patient has a systemic hypertension, shortness of breath, you have 60% ejection fraction, and your E and the A, take a look at that. They are getting fused, and your E is measured as 0.58. See here that the E and the A waves are fused. Now, if you look into tissue Doppler, this is one advantage when you look into tissue Dopplers. At least there you don't see that much of fusion. You can see the E and the A waves separately. And the measurements are 9 centimeters per second and 7 centimeters per second for the septal. The septal typically is lower than the lateral wall. And then when you try to look into all the parameters, you see the septal E prime is 7, lateral E prime is 9, E by E prime looks normal, LA volume index is normal, less than 34, and the TR velocity is 2.2. So what is this situation? This is a situation of a normal diastolic function. Even if there was one abnormality present, this is a situation with a normal diastolic function. Then you have a second situation where you have a patient with hypertension, type 2 diabetes mellitus, patient is Henvacher class 2. Ejection fraction is completely normal. There is no LV mass which is increased. There's no LVH. And then you look into the transmitral velocity. You look into the LA volume. Now you see here that the patient has a E by A ratio of 0.75. LA volume is increased. And then you look into the tissue Doppler. You have tissue Doppler which is reduced. You can see one of the E primes is lower, 6 centimeters per second. And when you look into the overall picture, there are the TR velocity is not increased, but there are 2 positives, that is septal and the LA volume. And you would probably think that the E by A ratio, the likelihood of this patient being diastolic dysfunction is very high, but you need a little bit more confidence. Then you will call this patient as indeterminate and ask for a few more measurements. But typically, if you are doing this on the patient, maybe you will go to pulmonary veins, or maybe you will try to see if you can ask for an exercise stress test. So what I'm trying to say that when the confidence, the indeterminate means that your confidence to clearly say that the patient's symptoms is driven by the diastolic dysfunction is not so true, and you want to be more specific about this observation, you will ask for more measurements or ask for exercise to be done. So The highlight is therefore when you have an indeterminate, doesn't mean that you stop there. You want to ask more questions. I have not solved the problem. I'm very suspicious of diastolic dysfunction, but I need more information. So that's the strategy that you want to take. Now, this is a situation of a patient who has now been asked, and you're trying to look into diastolic function. Here you see that the patient has clearly elevated systolic dysfunction. Ejection fraction is reduced. And the transmitral filling pattern is shown here. The E by A ratio is 0.9. You have E by E prime averaged, which is 12. LA volume is 30. Now the question is this patient having diastolic dysfunction? The answer is yes, absolutely. This patient has systolic dysfunction, has diastolic dysfunction. So the next question is, this patient has diastolic dysfunction, so the story doesn't end there. How severe is the diastolic dysfunction? So when you have already clinched diastolic dysfunction in presence of systolic dysfunction, you want to go towards looking at the severity. Now, this table becomes a little bit more complicated from the 2016 guidelines, but I'm going to just give a summary figure that will be a little bit more easier approach. So what they're trying to do is they are asking you to ask the question, what do you think is the LA pressure? Is the LA pressure elevated, mean LA pressure? Is it normal, low normal, elevated? That's the question. Now, if you see that the E by A ratio is less than 0.8, then typically that coincides. This is been our understanding for a long time. This indicates typically impaired relaxation. And then you're looking for what are the other parameters. Is the E by E prime elevated? No. TR velocity high? No. LA volume index elevated? No. It may or may not be elevated. But if you don't have consistent observation of elevated filling pressure by all the abnormal categories being present, then typically this will go towards grade 1. So grade 1 typically is talking about, looks like this patient has got a impaired relaxation pattern, and there is no much concordance or evidence to suggest elevated filling pressure. So this is a grade 1. Versus the other extreme, that is a grade 3. Grade 3, you have almost everything is abnormal, and the transmitral filling pressure is more than 2. So you have a restrictive filling pattern, and everything looks increased, abnormal. It's easy. It's grade 3. Now, what happens if it is not grade 1 or grade 2, and the pattern is a pseudonormal pattern, which is between 0.8 to 2? Pseudonormal pattern, and then you look for other abnormalities. If other abnormalities are present, then you have an elevated filling pressure. So it is a pseudonormal filling pattern with confirmation of other elevated filling patterns, elevated filling pressure. That is a grade 2. So it's not different from what we learned from what we were taught by our leaders from Mayo Clinic and Cleveland Clinic on how do you assess. It is the same. The only caveat is that sometimes you can have grade 2 dysfunction, and you may not be very sure about is it really grade 2, or I'm not able to satisfy. Looks like it could be grade 2. I'm not really sure. So you have an indeterminate category that comes in the grade 2 filling pattern, where you're not really sure, and you might have to say, well, it looks like it is indeterminate. So that's the only difference. And another difference is that you can have a grade 2, a grade 1 looking pattern, but it has also shares features which are of grade 2, then you go towards grade 2. So if you have a impaired relaxation pattern, but you have higher scores of elevated filling pressure, then you will move towards grade 2. Vice versa, it looks elevated filling, a grade 2 pattern, pseudonormal, but not everything is getting. Either that is indeterminate or is a grade 1. So that's the only difference in the guideline that they have suggested. But for simple reason, just think about grade 1 and the grade 3. Life becomes simpler. Whenever you're in grade 2, you need to just take into consideration, do you have more features to suggest elevated filling pressures or not? If you have, then you are comfortable to say calling it a grade 2 because there's an elevated filling pressure. So for example, this is a patient. You can see here the E by A ratio is suggesting an impaired relaxation pattern. So E is smaller than A. But when you look into other parameters, E by E prime, this is increased, LA volume is increased. So could this be a grade 1 filling pattern? The answer is no. This patient has an impaired filling pattern, but all the other parameters are looking abnormal. They're elevated. And therefore, in that situation, it will be a condition where you will call it as a grade 2 filling pattern. So just one of the caveats where you need to see the difference between grade 1 and grade 2. And that's the only thing that you need to consider as a variance from what we were told in the past. Now, this guideline document has been validated, and it definitely works well, but there are caveats. There are problems, and I think I'm expecting that this will be modified in the near future. There's already a modification suggested from Mayo Clinic, and there is some intense debate that is going around. But you need to know that there are several patients who may end up not being able to grade, so they'll be indeterminate. In that situation, ask for more help, look for more parameters. You may have situations where some of these parameters may not be measurable. So what do? Then typically it becomes difficult to apply. You start thinking more in terms of indeterminate, looking for other variables, or there are some modifications that have been recommended, but just make it easier, make your life easy by asking for more variables and looking for more support to go for features to suggest elevated filling pressure. Difficulties in applying in atrial fibrillation, presence of mitral annular calcification, valvular heart disease, presence of arrhythmias. These are all the challenges that still continue. Experts can continue to tease out, but these are situations where one has to be extremely careful. My suggestion is go for exercise performance, look for deterioration of the parameters, or if you're not very sure, ask your colleague to do a cornea angiogram and check for the cath pressures, because typically corneal artery disease will be required to be ruled out in any of these patients. Diastolic stress testing, very quickly, you can do either both the bicycle. You can do it either on ergometer, or you can do on supine bicycle ergometer, the treadmill or ergometer. Either can be done, but you're looking for a deterioration of E by E prime. Again, a tough exercise. Stress tests are tough to interpret, so quality control is very important. Very experienced labs and experienced hands can only do that well, but definitely this is a good tool if you know how to do it well. There are newer indices, strain, LS strain. LS strain is very promising. Looks like a very important a variable that will soon be merged into the guidelines. But remember that life is not easy, and probably more solutions, easier solutions will come from machine learning techniques, which will provide automated input of variables and will tell you easier instrumentation techniques for busy clinical practice. And I will touch upon this tomorrow. So to summarize, diastolic dysfunction provides you insights and is useful typically for answering the question in clinically challenging situation where shortness of breath cannot be teased out. The reason for that also is helpful for patients management, particularly when you're trying to adjust for diuretics and you want to adjust your treatment profile. And you want to go from an initial assessment at rest, and always know that resting state is not equivalent to exercise state. And typically, if the patient is complaining of exertional symptoms and your findings are normal, then you want to do some exercise to understand that parameters and look for more help and go for cardiac catheterization if you really are interested to get the final answer about the LV filling pressure. Thank you very much.
Hi, Shantanu. And hi, Partho. How are you? No volume. Okay, Partho, there is a question for you that sometimes you are not able to grade the diastolic dysfunction.
I'm happy to take some questions.
Hi, Partho. Can you hear me?
Yeah, hi Partho.
Hi.
Yeah. So I think Dr. Fulwani wants to get in touch with you.
Hello. Hi, Partha.
Hi, Mahesh.
How are you?
I'm good.
There are multiple questions for you. It says that despite multiple attempts, we are not able to grade the diastolic dysfunctions. Can you briefly tell them or give them some practical tips? How do you do it?
Yeah, so that's what I said. The practical tips are, again, diastolic function assessment requires you to understand the concepts which I presented. So go for understanding. First step is diastolic dysfunction present or not. So if you see systolic dysfunction, if you see LVH, if you see wall motion abnormalities, coronary artery disease, you have diastolic dysfunction. Period. The next step is if you don't have these problems and if you want to understand, look for how many parameters you can find. Do you have relaxation abnormality on E prime, transmitral E by E prime ratios? Are they extremely abnormal? Is the LA volume increase? TR velocity is increased? You have many of these parameters are abnormal. You have diastolic dysfunction. If you then want to ask the question of grading the diastolic dysfunction, simple. Just look at the transmitral filling pattern. If it is E and A ratio suggests a impaired filling pattern that is less than 0.8, then most of the time it is grade 1. So the LA pressures are not high. If it is E by A is more than 2 and everything is abnormal, it is a restrictive filling pattern that is grade 3. In between is the pseudo-normal filling pattern where you need to ask for how many more parameters I can see abnormal. If more the number of parameters you see, you know that this is a pseudo-normal, not a normal pattern. So it becomes a grade 2. So the only thing that you have to do is ask the question, clinically, is this symptom related to presence of an abnormality in the left ventricle? How many parameters are abnormal? If my left ventricle is very abnormal, I don't need to ask the question, is diastolic dysfunction present or absent? It is present. Then the question is how bad it is. If you have more number of abnormalities, then typically the LA pressure is high. And if it's lower number of abnormalities, the pressure is lower. So it's a lower grade of diastolic dysfunction. So that's pretty much it. And only experts know how to move. And I mean, this is only heuristic and expert opinion, but there may be simpler ways to grade and do diastolic dysfunction in the near future because there may be automated tools. And I think that's where the direction of the search is happening right now. And hopefully the conundrum of diastolic dysfunction assessment would be solved.
So 2-3 quick questions. Diastolic dysfunction assessment in MAC and in atrial fibrillation. Yes.
So mitral annular calcification, beware that it can confound. If you have only mild MAC, you can still use the algorithm. If you have severe MAC, you cannot use the algorithm. Now, Bill Zogby from Houston has proposed, and along with Sharif Nagi, some of the modifications of how to assess diastolic dysfunction in presence of moderate to severe MAC. But these has not been confirmed in many places. So I would just say that if you have severe MAC present, then you may have difficulty in using it. But if it is a mild MAC, you can apply the existing guideline. If you have moderate to severe MAC, I would not apply the guidelines, and I would be careful to make any conclusions because these are only single centers that have confirmed some observations. But the guidelines have also proposed some modifications. But I think it is not widely used, and caution is required to assess anything related to filling pressure. Maybe I don't know what they do at Mayo Clinic right now, but
right.
I think
yeah,
Sunil can also answer that question.
Sunil, can you have Sunil unmuted, please? Yeah, Dr. Sunil Mankad is joining us from Mayo Clinic. Sunil, what's your opinion with in presence of MAC?
I think if you have moderate or greater mitral annular calcification, you have to use other tricks of the trade. And, you can still look at other parameters. Is there pulmonary hypertension in the absence of any other cause? Is the left atrium very big? So there are other parameters you can look at, but not over E prime when there's moderate or greater MAC. And it's interesting, a few other observations that people of the standard of Partho and Dr. J.O. have made are when you have the presence of left bundle branch block, it turns out E over E prime doesn't work as well either, especially if you're using the septal E prime. And it was mentioned about AFib. It can be very tricky to assess diastolic function in AFib, but one of the things you can look at is the peak mitral inflow, the peak E wave. And if that does not vary, despite variable cardiac cycle lengths, but the E wave remains elevated and not changing, that's a pretty good bet that filling pressures are up. I don't know, Partho, AFib is tough, but maybe you can comment on that as well.
No, I think that you're completely right. So what Sunil is saying is that if you have changing RR interval, but your E wave doesn't change and is very tall, then you know that the LA pressure is so high that even the changing RR intervals and respiratory mode, nothing is making a change. It's a very high pressures, and that is again an indication of an elevated LA pressure. So you're right. And some people have even applied E by E prime ratios in atrial fibrillation, but it's tricky. But some of these small things are probably best used by experts. So typically when you see atrial fibrillation, I would be very cautious. Because otherwise it could so happen that there may be a lone AFib in a young individual and you will call that patient to have severe diastolic dysfunction. So there could be a lot of misgivings when, you just apply in a blinded fashion some of the guidelines and you don't, again, the whole thing is that you don't apply it without the clinical story. Understand the clinical story and then try to apply it. So you have to integrate the whole picture, not just use guideline. This is what it's saying. Guideline is a guideline. If it doesn't fit with your clinical story, you should be suspicious. I think we need to be very careful as how you apply the guidelines. And I think there is continued interest in seeing more.
Right. So, Partho, there are a lot of questions on diastology, and I'm sure people are still having a lot of problems. You did try to simplify. A couple of 1 or 2 questions before we move on to Sunil. Sometimes all parameters look okay, but the left atrium looks dilated. Then what?
No, the left atrium can be dilated because of for example, if a person has anemia, the left atrium can dilate. All chambers can dilate. If a person typically, if is a marathon runner, the left atrium can dilate. So there are more reasons for left atrial dilatation beyond simple diastolic dysfunction. Now, one parameter, therefore, that people are doing is that they're looking into the performance of the left atrium when it is dilated. So this is called as LA strain. And LA strain is found to be fairly useful in these situations. So if you're not sure, LA is dilated, is there filling pressure high, and you look into LA strain, and if it is abnormal, you are basically suggesting a dysfunction of the left atrium. And you're trying to classify it from a physiological enlargement of the left atrium, which is a question that you're asking.
There are a few more questions, Partho. Someone has asked that if the LA wall appears thick, do you assume that this is diastolic dysfunction, even though the parameters do not suggest it?
So the question that is the LA wall thick or LV wall thick? LV. So if the LV is thickness, concentric remodeling is very common. You want to make sure that you measure and show that the LV mass is increased. So there is hypertrophy. And if it's not a physiological hypertrophy, it's a pathological hypertrophy. For example, patient has systemic hypertension, renal failure, or whatever, hypertrophic cardiomyopathy. You have to say that the patient has diastolic dysfunction. You don't worry about trying to say whether it is present or not. You then worry what is the grading? Is it LA pressure is high or LA pressure is low? So if the LVH is present, hypertrophy is present, diastolic dysfunction is present.
So pathological hypertrophy of left ventricle suggests diastolic dysfunction.
Correct.
But I think, Partho, I think we will have to cut short because of lack of time, but I'm sure we will have more discussion, and if you can stay back, that would be great. We have Sunil with us, Sunil Mankad. Can you start sharing your screen, please? Sunil Mankad was with us last 2 years in Nagpur for Echo Nagpur, and he is a professor at Mayo Clinic, Rochester. Sunil, can you unmute Sunil Mankad, please? Yeah. And I can see Dr. Luigi, Dr. Nitin Burkule, Dr. Vinayak. I think everybody has joined. Dr. Mankad, please.
Hello, can you hear me okay?
Yeah, you're good.
All right, good morning, Shantanu and Mahesh and my dear friends. And in the next 20 minutes, we're going to cover something that we see in the cardiac intensive care unit all the time. And echo really plays a pivotal role in diagnosing what the cause is of a loud systolic murmur post-MI. And I have no disclosures. So echo is really the ideal tool to use in acute myocardial infarction. It's non-invasive, portable, it's low risk, and we can do serial comparison studies, and most importantly, information is quickly available. This is data from Dr. Hochman's famous study, the SHOCK trial, and we can see the #1 reason for shock in an acute MI is pump failure. 85% of the time that's the case. But it's these entities down here where echo is really pivotal. Now, echo does make the diagnosis of pump failure as well, but to separate out different causes such as a VSD, mitral regurg, and some others is really where echo is very important. So let's start with the first loud systolic murmur post-MI. We see this patient has had an apical myocardial infarction, and we see this irregularity in the ventricular septum. It's a very serpiginous and highly irregular discontinuity in the atrial septum. We put color Doppler on, and we see that there's quite a bit of flow from the left ventricle to the right ventricle there. In addition, there's quite a bit of tricuspid regurgitation as well, but really it's this flow that's the key. Now, this loud systolic murmur will almost always also have a thrill. So that's one of the clues that it's a ventricular septal defect. Now, how do we manage ventricular septal defects? Well, historically, we would just kind of wait a few weeks and see if you lived. And if you lived, then we would consider surgery. And the reason is to try and operate acutely on patients with necrotic myocardium is very difficult, because if the surgeon got in there and tried to sew into it, the tissue would just tear because it was so necrotic. And the ideal time to operate has now become clear that it's probably at least 7 to 10 days after the infarct. But sometimes you don't have a choice. Now, this is the GUSTO-1 study, one of the fibrinolytic studies. And interestingly, when you give lytic therapy, this complication occurs at day 1, not day 3 to 5 after the MI. Now, this is observational, non-randomized data. And if you look at the observational, non-randomized data, people who went to surgery had a better outcome than people that were treated medically with a VSD post-MI. But clearly, there was a reason why the surgeon accepted these patients. They probably looked better and had less comorbidities. These are some of the risk factors associated with the development of a VSD: older age, an anterior MI, being a woman, and interestingly, no previous smoking. So the ideal time to operate is just before you start developing, or just as you're developing, organ system dysfunction. If you're not developing organ system dysfunction, and you can support the patient perhaps with an intra-aortic balloon pump and monitor things, but they're perfusing their organs adequately, then you'd like to wait 7 to 10 days to let that necrotic tissue become a little bit more like a scar so the surgeon can sew into it. Now, here's another ventricular septal defect, but the location is a little different. This was an 84-year-old woman, day 5 post-MI, suddenly developed some pulmonary edema and a loud systolic murmur. And we can see here out towards the distal septum, and she's had an apical MI, as you can see here. There's a ventricular septal rupture or ventricular septal defect with flow from the LV to the RV. Now, she's 84 years old, and, you know, we did improve her heart failure. And then after multidisciplinary discussion with our cardiovascular surgeons, we decided to place a VSD occluder device in the cath lab. And in fact, probably half the time now, that's what we do. Rather than taking him to the OR, we place an occluder device. Now, there is very necrotic tissue, so just like with operating, if you can wait 7 to 10 days and let some scar tissue form, that's a better solution. And in this case, that's what we were able to do, and we had a good result with a VSD occluder device placement. But you've got to have a multidisciplinary discussion. Talk to your cardiac surgeons, talk to your interventional cardiologists, look at the location of the VSD. That's very important. If it's in the mid-septum, that's perfect for an occluder. The distal septum can be difficult because sometimes there's just not enough room out there, but in this case, it worked out well. On the other hand, here's a very poor location for a cath lab solution. We see here in a short axis view that there's a ventricular septal rupture, and it's quite large, and more importantly, it's at the base of the heart, very close to the mitral apparatus. Because of its location, it will be nearly impossible to try and close this in the cath lab. Now, our surgeons would probably take an approach of going through the tricuspid valve and closing it from the RV side, but a lot of different solutions available surgically. But it's a tough situation to deal with, and the location is something that we need to be sure of by echo. Now, one of the most ominous signs if you take someone to the OR is if they have significant RV dysfunction. Here's a TE, once again, the right ventricle, left atrium, and we see this irregularity in the ventricular septum in this patient with an apical MI, and sure enough, there's a ventricular septal rupture or VSD. And it's pretty high flow. We can see the irregularity in the ventricular septum, but there's also significant RV dysfunction. And you can tell by color Doppler, but especially when we give a little agitated saline, you can see that there's definitely right to left shunting, meaning that the RV pressure is higher than the LV pressure for part of the cardiac cycle. This makes the operative mortality significantly higher in this situation. So make sure we always assess RV function as well in the setting of a VSD. All right, so let's move on to another cause of a loud systolic murmur post-MI. This was a 66-year-old man that was in a car accident. He had multiple injuries, loss of consciousness, confusion. He had multiple fractures, including an open compound fracture of the right leg, closed fracture of the left leg, multiple back and rib injuries, and blood pressure is okay, but lactate is 6.8. He is in shock. And he's in the CT scan where our trauma surgeons are doing a pan CT to try and find out all of his injuries, and he suddenly has hypotension and complains of chest pain. And there was a subtle abnormality in the EKG as shown here. Even our orthopedic surgeons recognized that there's a major problem here and immediately called us. He was having a rather large anterior myocardial infarction. We had a multidisciplinary discussion, and the trauma surgeons pretty much wrapped up all of his injuries to stop the bleeding. And there was agreement, given the very large anterior MI, his hypotension, hemodynamic instability, that we had to proceed with coronary revascularization. And that's what we did. And here is this cath. We can see that the LAD is totally occluded, stumped off proximally. There is a significant disease in the circ, but that was fixed at a later time. The RCA had no significant disease. So he underwent revascularization. Here's the pre-study, stumped off LAD, and post-study, he had a pretty good result. There's some distal embolization, but overall the result was very good. Despite that, he remained in shock with systolic pressures as low as 50 and intermittently receiving boluses of fluids. He was started on dopamine and norepinephrine. An intra-aortic balloon pump was placed. He's intubated and sedated, but he's still somewhat hypotension. And we did a quick look echocardiogram. The images were not very good. We could see a tiny pericardial effusion, and I would tell you that his IVC was actually normal sized, but this was the best view we had of the LV. We really couldn't see it very well. The RV looked okay. Because of all of his injuries, and he was a relatively big man, we of course proceeded with transesophageal echo at this time. Now, when we do the TE and the transgastric review, we see that the left ventricular function is not that bad. This is not pump failure. This is not the cause of this patient's shock. But then we go to the long axis view here in the mid-esophagus, left atrium here, left ventricle here, the aortic valve, which barely opens, and then something going on here with the mitral apparatus. We see severe systolic anterior motion of the mitral apparatus. In fact, here's a zoomed in view showing us the SAM, or systolic anterior motion. The aortic valve is barely opening. We see turbulence in the left ventricular outflow tract and some degree of mitral regurgitation, not too bad, but definitely turbulence in the LV outflow tract. And in fact, when we look at the gradient and the transgastric view in the left ventricular outflow tract by CW, we see that the peak gradient is over 5.8 meters per second. So this patient has severe dynamic outflow obstruction from SAM. So here's the situation beforehand, and we had given him inotropic support with dopamine and norepi, a balloon pump. With the TE probe in place, we stopped the norepinephrine, we stopped the dopamine, we removed the balloon pump there in the CCU at the bedside, gave some fluids, and here's the result. Now the SAM is much improved. The aortic valve is opening much better. And we can see that the gradient, which was 5.8 meters per second, is now really normal, 1.6 meters per second in the left ventricular outflow tract. And his left ventricular function, he does have a regional wall motion abnormality here, as you can see, but his LVEF is well preserved. And a few days later, we fixed the circumflex, and 2 weeks later, all of his injuries have been treated by orthopedic surgery, and he left the hospital. So this is an entity we need to recognize. This is a nice report from my friends in St. Louis. Dynamic left ventricular outflow tract obstruction with acute MI, and it can cause shock. Here you can see an apical MI and severe SAM. Now there can be severe mitral regurgitation as shown in this particular example. It does occur, but it's not from a papillary muscle rupture. The key is looking at the LV outflow tract, noting the SAM, and seeing the turbulence in the LV outflow tract. And then, of course, when we do CW, we see the characteristic late peaking dagger-shaped spectral Doppler pattern of a patient with dynamic outflow tract obstruction. While not as common as a VSD, it's probably more common than a papillary muscle rupture, and it's something you need to recognize. Importantly, there's been many reports in the literature. We're partial to Bill Armstrong from Michigan's report, one of the earlier reports in 1996. When the apex becomes akinetic in the setting of an apical MI, the basal segments become hyperkinetic and hyperdynamic. And that leads to a situation or environment that can lead to dynamic outflow obstruction from SAM or mid-cavitary obstruction. So keep in mind that's something to occur and can be a cause of a loud systolic murmur post-MI. And this can also occur in Takotsubo cardiomyopathy or apical ballooning syndrome. Patients with Takotsubo cardiomyopathy, about 10% of them will have significant hemodynamic instability and shock. And one of the reasons they can be in shock is shown here. This is a patient with no significant coronary disease, was cathed, has severe SAM and dynamic outflow obstruction, as shown here. You see the upside down Y with turbulence in the LV outflow tract, some degree of MR, and the characteristic late peaking dagger-shaped spectral Doppler pattern. This can be tough to manage, but probably phenylephrine is your best choice in the setting of a Takotsubo cardiomyopathy. And of course, volume, and if their blood pressure will allow, a little bit of beta blocker. All right, so let's go to the final systolic murmur that we'll talk about. And this is shown here in this case from one of my mentors, John Gorson, a 62-year-old woman with chest pain and severe pulmonary edema. John did a TE, and it's shown here. You see that the posterior leaflet is flail, and more than that, there's the head of a papillary muscle attached to the posterior leaflet. And there's severe eccentric mitral regurgitation. This is, of course, a papillary muscle rupture. We can see the chaotic motion and the head of the papillary muscle right there, and a beautiful 3D, a view from the left atrium looking down, and we can see that it's a flail P2 with the head of the papillary muscle. Look at the transgastric view with the chaotic motion, and there is clearly a regional abnormality here in the inferior wall, but it's a little bit underestimated because there's so much mitral regurg. And here again is that flail posterior leaflet in this case with the head of the papillary muscle attached. And here again, just to show you the 3D, we see two torn chordae tendineae and the head of the papillary muscle. Now it's important to understand that both the posterolateral and anteromedial papillary muscles give rise to chordae tendineae that go to both leaflets. So regardless of which papillary muscle is involved, it could be either an anterior leaflet or a posterior leaflet problem. But finding the head of the papillary muscle is really the key. And here, just to summarize, this is the most serious complication of an MI. Most commonly involves a smaller infarct of the RCA or the circ, meaning the posterior medial papillary muscle, because the anterolateral papillary muscle has a dual blood supply. We have seen RV papillary muscle ruptures as well. Now, just to show you the spectrum of papillary muscle rupture, here's a case now of an anterior leaflet that's flail from a ruptured papillary muscle. This is a huge head of the papillary muscle that's ruptured. This is, again, left atrium, left ventricle for the fellows. Here's the anterior leaflet and very severe mitral regurgitation. And the patient went to the OR and had mitral valve replacement. But you can see here that this is the head of the papillary muscle and it's an anterior leaflet flail. But this could still be the posterior medial papillary muscle. Keep that in mind. Now, here's an interesting case. This was a gentleman that was helping to move his girlfriend out of his house because she broke up with him. He was moving her piano and suddenly had a heart attack. And in this case, we see again the head of the papillary muscle right there, but both the anterior and posterior leaflets are actually flail. This patient had torrential mitral regurgitation. It was all we could do to get him to the operating room with pink frothy fluid coming out of his endotracheal tube. But just keep in mind the spectrum of disease that you can see. It can involve the anterior leaflet or the posterior leaflet, irrespective if it's the posterior medial or anterolateral papillary muscle. Most authors agree that it's the posterior medial papillary muscle that's more often involved because it does not have a dual blood supply. Dr. Joe Duraney at my institution repaired this valve. Unfortunately, the patient could not repair his relationship. Now, one of the other things to look at is a partial papillary muscle, because now you have a little bit of time, maybe. The patient's not in fulminant pulmonary edema. And the key thing to look at is the chaotic motion on the left ventricular side of the mitral apparatus. Here we can see that the anterior leaflet is certainly overriding and probably partially flail. But look at this chaotic motion that every so often you see right there. That's the big clue that something is going on with the papillary muscle. It's hanging on by a thread. There's a significant regional abnormality here, as you can see, and then for a posterior wall. But it's that chaotic motion that's really the key. Watch it here. This is the Mayo Clinic format, so this is the left ventricle. But you see that chaotic motion on the LV side. The papillary muscle hasn't ruptured yet. It's not coming into the left atrium, but it's about to. And if you have time, you can get this patient to the OR in a much more safe situation. Because if you diagnose this, the patient will make it to the OR. And we've seen dozens of these cases over the years. And there is, of course, severe eccentric MR. And you can see that here. And you can see the large PISA without even shifting the baseline. So keep an eye out for the partial papillary muscle rupture as well. And how do these patients do with an operation? So I didn't mention, but VSDs, that's a tough operation. There are literature reports that mortality is as low as 30% with a VSD operation. In my experience, it's closer to 50% mortality if you take these patients to the OR. It's just a tough operation. But with papillary muscle rupture, it's gotten better over the years. This is Maurice Serrano's series. The operative mortality overall over a couple decades was 18.5%. But it was as high as 67% in the early 90s and went down to less than 10% in the late 90s. So it may be as low as about a 10% mortality. And guess what? If you live and survive the operation with a papillary muscle rupture, your outcome is just as good as those patients with an MI who did not have a papillary muscle rupture. So these patients definitely need to be given the opportunity to go to the OR. A VSD is a much more difficult operation. So we summarize the three causes of a loud systolic murmur following MI. A VSD, often with a thrill, papillary muscle rupture. These patients generally need an operation. But dynamic LV outflow tract obstruction with an apical MI does occur, and that can be managed medically with fluids, beta blocker, or perhaps an alpha agonist. So we covered a couple different things. Echo can also look at other complications of MI, but I showed you a ventricular septal rupture, dynamic LV outflow tract obstruction, and a ruptured papillary muscle. And I thank you very much for your time and consideration. And I'll open it up if there's time for questions. If not, we certainly can move on, and I'll be back for other talks.
Hi, Sunil. I'm Mahesh Fulwani.
Yes.
There are a few questions for you what is your protocol of doing echocardiography in ICU post-MI? How frequently you end up doing echocardiography? Is it every day or maybe alternate day or whenever required?
So our protocol is to do it once officially. So generally speaking, if you get revascularized, there could be a lot of stunned myocardium on the first day. So we generally, if the patient is stable, try to do it 48 hours out from their MI. Now, that being said, we have cardiology fellows, and they routinely do bedside point-of-care echoes almost on a daily basis on patients post-MI when in the CCU. So I don't think there's anything wrong with doing the echo daily. We don't charge for it, though. So we only do it once, and we like to wait a few days out, if possible, if they're stable. However, if they're not stable, then we'll do it right away. And especially if we think they've had larger MIs or they're in shock or heart failure, then we'll do the echo right away the same day or the next morning. But only one time officially. That being said, because we have cardiology fellows, they almost routinely do it on a daily basis.
That's what even we also keep on telling people, that we should do echocardiography post-MI patient almost daily in ICU, because it's very a dynamic situation. Things keep on changing hourly basis. So at least we should do an echocardiogram at least daily. As you said, you may not charge it, but for our learning and for patients' benefit, we should do it at least daily.
I think
it is done daily because our fellows do it daily, yes.
I think
but officially just one, but for charge, yes.
I think a very important thing you mentioned is that whenever a patient is on an inotrope, and if you're not getting the blood pressure up, try to look at the LVOT. And if the gradients, and if it's causing any obstruction, then you may have to change and modify the vasopressors, right?
Right.
Yeah, and it's important to understand that if you have a Swan-Ganz catheter in, that will not give you the answer. The filling pressures will be going up, 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 and you think that the patient's in pump failure, but that's not the case. However, echocardiography will give you the answer.
Yeah, I think we have Luigi with us, and Nat has joined. Can you unmute them, please? Luigi, hi Luigi.
Hi, Shantanu.
Hi. Nice to see you. So, any comments, any thoughts about Sunil, what he mentioned about the post-MI systolic murmur? And
that was a fantastic series of cases. I think it's very educational to see all these cases that usually takes years to see all these complications in just 20 minutes. That's a fantastic talk, and also a fantastic echo. About the management of those patients, I think we fully agree. In the early days, we try to operate the ventricular septal defect as soon as possible, but then we have learned that if we can stabilize the patients and waiting 1 week, 10 days, the likelihood of successful surgery is more and more. Only one thing that I would like to underline is that more and more, when with the 3D echo we see that the characteristics of the hole are feasible, we are trying to fix them with interventional cardiology instead of surgery. I think the case Sunil has shown is again something that probably we will see more and more, since we more and more are able to exactly characterize the size of the hole and the status of the tissue around the hole by echo.
That's an excellent point. Excellent point.
Thank you, Sunil. We move ahead to Luigi. Dr. Luigi Badano is the past president of EACVI and also the professor of cardiovascular medicine at the University of Milan. A phenomenal teacher focusing predominantly on right ventricle and also on 3D echo, and he has taught a lot of people all across the world. I welcome you, Luigi. Thank you for being with us, and you are going to highlight on the right ventricle. It is not neglected anymore. The prognosis of and importance of RV. So, if I can request Luigi to share your slides, please.
Can you see my slides?
Yeah.
Yeah, thank you, Shantanu. Yes, I fully agree. The right ventricle is not neglected anymore, and we are learning.
We are not getting your slides. Can you share the slides, Luigi?
I am sharing the slide.
Can you? No, we are not still getting it. How to do it?
Okay, let me see.
I can see you. You have to share.
Share screen.
I shared,
Share screen.
but I don't have the. Sorry.
It's okay. I mean, we can wait.
The presentation is here.
I think you have to go to share screen below.
Yeah.
Right. And then you can select your. Or else you have to show me your RV. I can see you. I have to see. Now we can. Yeah, now, okay. You have to just open it.
Can you see?
Yeah, you can see.
Now you go to presentation mode.
Open the presentation.
Yeah, I opened the presentation. Can you see it?
Yes, and please go to the slide share, full screen.
Yeah, I am full screen.
I think what is happening, you have to, I can see on the left side, no, can you go back?
I was there on the...
You're almost there.
Let me see what I can do.
I think you will have to, once you are in the same mode, maybe double click on that and it will open up.
Go to share screen.
Yeah, maybe you can, yeah.
Yes.
Yes.
Oh, can you see it?
Yes.
But it's not opening, sir. You have to just double click that prognostic value of RV.
Can you see the screen and the movies?
Not
no,
now.
I can see you.
Oh.
So please start the screen sharing option on the Zoom.
Yeah.
Share screen, green one.
I know. I cannot see on the files. Let me see. I cannot see the presentation in the board. Let me open it again.
We will wait. Don't worry about it.
Oh, no, I'm worrying at all.
Right.
Okay, let me see now if I can see. No. Okay. If I share the screen.
That deliver fast and reproducible results wherever you need them.
Huh? Right. Yes, we are getting you. Yes.
Yeah.
Okay, thank you. Sorry, it was something wrong in the... So I was saying that the right ventricle is not neglected anymore, as you said, and we are learning day by day how important is the function of the right ventricle for the prognosis of our patients in a lot of cardiac conditions. In these slides, you see just a few of them, but many more we are discovering day by day. It's also true that when we look at the right ventricular size with the conventional echocardiography, we are losing a lot of the potential clinical information because due to the peculiar shape and also function, I would say, of the right ventricle, the conventional indexes that are all indirect measurements of just one part of the complex function of the right ventricle are not completely depicting its function. A lot of improvements has been done with the 3D echocardiography, also because 2D echocardiography, as it is exemplified in these slides, can only encompass a minimum part of the endocardial surface and of the myocardium of the right ventricle. And we lose most of the surface of the endocardium and the muscle that are shown in green in this moving boitle. As you see, and however is the number of apical or short axis view that usually are just a few, we don't usually see more than 5% of the endocardial surface and the muscle. So what happens usually is that when we are asked to assess the function of the right ventricle, as it happens in these patients with the pulmonary hypertension, we end up with some contradictory results. For example, in this case, the TAPSE is normal or high normal. The fractional area change is mildly abnormal, and the S velocity of the right ventricular free wall is at the lower limits of normal. So we end up with the question, is this ventricle normal or abnormal? And usually we relied on a CMR that showed that in this case, the EF is significantly abnormal. But we have seen it. There are a lot of papers and meta-analysis showing that current 3D echocardiography can provide almost the same information. With the volumes, we are slightly underestimating them compared to CMR, but when we compare the ejection fraction, we are really, really close. It is important to do the ejection fraction. Yes, it is. Just three quick summary cases. This is an healthy subject. The central one is a patient with volume overload due to severe tricuspid regurgitation. And the one on the right is a pressure overload of the right ventricle, pulmonary hypertension. As you see that despite the TAPSE in the two patients overloaded, the right ventricle is lower than in the normal subject, but they are still in the range of normality. And so TAPSE doesn't tell us what is happening in those ventricles. But when we measure volumes and ejection fraction, we have all clear. In the healthy subjects, both the volumes and the ejection fraction are normal. In the patient with volume overload, there is an increase in the volumes of the right ventricle with a normal ejection fraction. And in the patient with pressure overload, despite the volumes are normal, the ejection fraction is moderately severely reduced. And 3D echo is particularly important in all those conditions where the TAPSE may be impaired. For example, in a post-cardiac surgery patient, post-heart transplant patient, in some cardiomyopathies, where despite a severely impaired TAPSE, in this case was 6, the patients relies more on the radial shortening on its bellows effect. And you can see here, looking at this series of transversal cut planes, that the radial function is normal or over normal. And in the end, the ejection fraction of these patients is 62%, despite there is almost no longitudinal shortening. And this is because the function of the right ventricle is much more than just the longitudinal function. And this also translates in a prognostic role. That is the topic of this presentation. This was one of the first reports showing that 3D echo ejection fraction of the right ventricle in patients with pulmonary hypertension has an ability to predict events much higher than the conventional TAPSE or fractional area change that we are usually conventionally. And the predictive power of the right ventricular ejection fraction is really close also to another index we have got with the new echo technologies, that is the longitudinal strain of the free wall. We also have learned that the ejection fraction of the right ventricle is lower in the normal than in the left ventricle, and the cutoff value is 45%. And in this large population, more than 400 patients, those are consecutive patients coming to the echo lab for the assessment of their cardiac function. They were followed close to 4 years, and you see that just having an ejection fraction that is normal or abnormal of the right ventricle make a lot of difference in terms of survival over 4 years. And the predictive power, once again, of the right ventricular ejection fraction, that is the green line, is significantly higher than the conventional TAPSE, that is the blue line, of the fractional area change, that is the red line. These data were also confirmed by a very similar study performed in Japan by the group of Masaki Takeuchi, and also they showed that the right ventricular 3D right ventricular ejection fraction is a strong predictor of both cardiac death and also major adverse cardiac events, that is occurrence of ventricular fibrillation, death for all causes or rehospitalization. But there is much more. This is another study made by one of our fellows, Elena Surkova. That's again a quite large cohort of patients with clinically indicated echocardiography. She performed the 3D echo on the left and the right side, and divided the patient in 4 groups. Group 1 with the normal, both the left and the right ventricular ejection fraction. The group 2 with reduce the left ventricular ejection fraction but preserve the right ventricular ejection fraction. The opposite is group 3 with the normal VEF and reduce the right ventricular ejection fraction, and of course group 4 with both ventricles that have depressed ejection fraction. The patients were followed for 4 years, and the outcomes was evaluated both in all-cause mortality and in cardiac death. And you see that when you stratify the patients with the left and right ventricular ejection fraction for both all-cause mortality and cardiac death, is much worse to having a reduced ejection fraction with preserved left ventricular ejection fraction, that is the green line, than having the reduced left ventricular ejection fraction with preserved right ventricular ejection fraction. Of course, when both ventricles are impaired, you are the worst prognosis. But this is a strong point versus the prognostic role of the right ventricle. And finally, we can also grade the extent of the severity of the impairment of the right ventricular ejection fraction, not just anymore normal or abnormal. This is a cooperative study between Padua and the University of Kitakyushu in Japan. We developed the partition values to define normal, mildly reduced, moderately reduced, and severely reduced ejection fraction. And then we asked our friends in Japan to validate those cutoff values in their population. And you see that despite there were 2 completely different populations, Caucasian and the Japanese, studied in 2 different institutions, the strong ability of the different grades of right ventricular ejection fraction to stratify the prognosis of those patients. However, we should remind that the ejection fraction is not just right ventricular contractility, and particularly for the right ventricle, the ejection fraction is really dependent on the loading conditions. This is an interesting study showing the change of the stroke volume of the left ventricle and of the right ventricle for the same increase in the ventricular afterload. And you see, as we all know, that the right ventricle is much more sensitive to the increase of the afterload and reduces the stroke volume. So we should not rely just on the ejection fraction when the loading condition of the right ventricle are altered, because this is just a chamber function parameter, but we should move to assess the right ventricular myocardium function. And today we can do it just measuring the deformation or the strain, and particularly the longitudinal strain in the free wall. This was known since many years and has been shown in pulmonary, particularly in pulmonary hypertension. There are several papers on that showing that when you have a reduced free wall longitudinal strain, the prognosis of your patients is significantly worse. And also, this is a large study made by the Mayo Clinic, 400 patients, and in pulmonary hypertension group 1, group 3, and group 4 of the world classification. And they stratified the time from the first cardiac event, and you see that with the decreasing longitudinal strain of the free wall of the right ventricle, you have a shortening of the time of major cardiac events. There are a lot of papers that have shown the prognostic value of the longitudinal strain in pulmonary hypertension. This is the condition that has been studied much. And here I try to summarize all those papers just to show you that the critical cutoff values is around 15%. Also important is to assess the strain of the free wall of the right ventricle in patients with heart failure, both in patients with the reduced ejection fraction, failure with the reduced ejection fraction. In this case, also the global strain, that is the one that includes the septum, has a similar prognostic value to the right ventricular free wall. And once again, the cutoff value comes back, the usual number around 15% is the value that makes the difference between patients who will have events and those who will not have events. Again, another very recent study, an Italian one, again in patients with heart failure, reduced ejection fraction. Those are patients who were selected for having TAPSE in the normal range, so higher than 16 millimeters. And you see that despite those patients have a TAPSE in the normal range, once again, when the free wall strain is below the cutoff of 15%, the likelihood of events changes almost, become 3 times, from 9% to 30%. Another very interesting area of use of the right ventricular free wall strain is in the assessment of the right ventricular function in patients who are candidates to VAD implantation. You know that in those patients it's critical to assess the function of the right ventricle. Otherwise, you can implant a device that improves the function of the left ventricle, but then the right ventricle fails, and you have wasted your money and worsened indeed the prognosis of your patients. This was also confirmed by Magunia and co-workers, showing that both the right ventricular ejection fraction, that also the right ventricular free wall strain, were both highly predictive of the outcome on patients after VAD implantation. And something new that is really actual with the current situation worldwide, the right ventricular function is also important in assessing the prognosis in patients who survive COVID-19 syndrome. And in those patients, those who have an impaired right ventricular longitudinal strain have decreased survival compared with the patients that after COVID preserve their right ventricular function. And this is a paper, again, from our lab that is going to be published soon in the European Heart Journal Cardiovascular Imaging. Almost 500 consecutive patients undergoing echo for assessing the left side structural heart disease, showing once again that even in this general population, not selected for any particular disease, the independent value of the right ventricular free wall longitudinal strain, and particularly also in patients who had the normal TAPS, confirming once again the additive role of the right ventricular longitudinal strain over conventional echocardiography in predicting the prognosis of our patients. Now we also have a standardized approach to measure the strain that has been published a couple of years ago as a document of the ASCVI IASC Industry Task Force to standardize deformation imaging, with all the tips for a correct recording of the images and measuring of the data. And finally, we also have a dedicated software package and to the right ventricle. All the major companies has developed a dedicated software package, and so we don't need anymore to adapt the software developed for the left ventricle to assess the right ventricle. So just to conclude, I would say that the state-of-the-art ecosystems allows a comprehensive and physiologically sound assessment of the right ventricle. It's important because it's accurate, provides, if the images are adequate, the information that are similar to those provided by the CMR, and has also a strong prognostic value. In patients with significant overload, either volume or pressure, the measurement of the longitudinal strain, particularly the right ventricular free wall longitudinal strain, is less loss dependent than the ejection fraction and has an increased value. And we have to remember that the strain as well as the ejection fraction are significantly related with both the disease severity and the outcome of those patients. Thank you very much for your kind attention.
Thank you, Luigi. Amazing presentation, fantastic information. We have got a good number of questions for you. How do you assess RV diastolic function?
We don't assess routinely RV diastolic function. We have done for a couple of studies just trying to mutuate what we do with the left ventricle, so the E over E prime ratio for the right ventricle. However, we have to be careful because there is no validation of that, and the hemodynamic environment in which the left ventricle works is completely different from the right ventricle. So I'm sorry, but I don't have a direct experience in assessing the diastolic function in terms of prognosis.
Right. I think very important question. In pre-operative assessment for non-cardiac surgery, any role of RV function assessment? So if a patient is going for a surgery, a non-cardiac surgery, let's say fracture surgery, do you assess, why is RV function assessment not included routinely?
I have to say that as you have seen, with both the ejection fraction and the right ventricular strain, we have seen also that in consecutive patients that comes to the echo lab for an echo study, there is a strong prognostic value. So if the images are adequate enough, we assess the right ventricular function both with the strain and ejection fraction in every single patient. And this is also very convenient today because the new software are all semi-automated, so it's very quick and it offers additional prognostic value.
So do you mean to say that if there is RV dysfunction, either by TAPSE or RVS prime or RV lateral strain, reported in a patient going for a non-cardiac surgery, it has a poorer outcome?
No, we reported that and underlying that they have to be careful with the feeling of the patient because there is a right ventricular dysfunction in beyond. I think this is an important information that the anesthesiologist should know, particularly in patients who undergo abdominal surgery or vascular surgery when there is a great fluctuation of the load due to the hemorrhagic characteristics of those surgeries.
Yeah. Hi, Luigi. Is there any
Hi.
hi? Is there any point of discussion that RV-PA coupling in a patient of pulmonary hypertension? Should we also start saying that?
Yes, I think that the patients with the pulmonary hypertension are those who have been studied more with the new echo technologies, and all the assessment of the prognostic value of the right ventricular ejection fraction and the strain started exactly in those patients. So in those patients where if we are able to obtain adequate images, and this is absolutely critical, not to attempt the ejection fraction or the strain when we don't have good enough images. Otherwise, we just provide rubbish instead of information. But when the images are moderately or good quality, then we can really provide added value.
Okay, someone is interested in knowing what is the value of RV strain below which it is abnormal or prognostically it is bad?
Okay, abnormal is below 19, prognostically bad below 15.
Okay.
Perfect. And is severity of pulmonary arterial hypertension a good correlation for RV function?
No, I don't think so, because the afterload of the right ventricle, that is the pulmonary hypertension, is a confounder particularly for the right ventricular ejection fraction, but also for the strain, that is less load dependent but not completely load independent measure of myocardial function. So you can have still a decent contractility of the ventricle, but if that ventricle has 80, 90 millimeters of mercury of pressure in the front, both the strain and the ejection fraction can be severely impaired.
So very interesting question. What percentage of patients in your lab do you do RV function? I think it is 100%.
I would say the last estimate we have done last year for answering a reviewer was 85% of consecutive patients. We have both ejection fraction and strain. A little bit more strain, but if we include ejection fraction, 85%.
So I think the key point is we should do it, try to get good images and get all the values. That's important.
Yeah, I don't think why we do it for the left ventricle. We don't do it for the right ventricle, despite there are a lot of proofs of the equal or even greater prognostic value.
So finally, I think we should end up by concluding that apart from left ventricle, we should pay more attention or equal attention to right ventricle by saying it's TAPSE, right ventricular free wall strain, and right ventricular ejection fraction, if possible, by 3D echocardiography, right?
That's absolutely true. But also you have seen that independent of TAPSE, even in patients with the normal TAPSE, right ventricular strain can still differentiate also ejection fraction patients with better or worse outcome.
So we should do both or three parameters: right ventricular TAPSE, right ventricular free wall strain, and ejection fraction.
I would say we should try to obtain most of the information, and then according to the information we have, we should interpret the function of the right ventricle and provide a clinical feedback to the clinicians.
Perfect. We are also joined with Dr. Nat Pandian. Can we unmute Dr. Nat Pandian?
Hi, Nat.
Hi. Is it unmuted? Yeah. Hi, Nat. So we have. Is it there? Yeah, I can see.
Can you hear me?
Hi, Nat. Is there a lag? So what's up? No, it's coming. Great.
So please tell him to unmute himself again.
So, Dr. Nat, can you unmute yourself?
Yeah, I just did.
Yeah, we can hear you. Great. Welcome to
Okay.
Nagpur.
Now I need the PowerPoint, right?
Yeah.
Share screen.
Luigi is telling hi to you. Can you listen to him?
Okay. Can you see the PowerPoint?
Not yet. Yes.
I can see
Yes,
here.
we can see you.
Now, how about the PowerPoint?
You can see.
Yeah, we can see you with the PowerPoint and with the hat.
Okay.
Great.
Now, ready?
Ready.
Okay. Good morning, everyone. Thank you, Mahesh, and thank you, Shantanu, for this invitation. We'll spend a few minutes talking about aortic stenosis. Long time ago, I thought I knew about everything about aortic stenosis. Not only me, a lot of people thought so too. But now, as years go by, we realize how little we know, how we are still learning. The fundamental problem in aortic stenosis, and we will predominantly concentrate on calcific aortic stenosis, is a calcific deposition, fibrotic changes, and bottom line is a reduction in the aortic valve area. That leads to all the other issues, hemodynamic perturbances, and syncope, and chest pain, and so on and so forth. Now, this is in terms of clinical aspects. This is a classic slide people keep on showing. Please don't. It's totally out of date. And people don't start developing symptoms at 40s and 50s. Usually it takes much longer. And once you have symptoms, it's not necessarily with a failure, syncope, angina, it's bad. Even if there are no symptoms, if it's a highly critical aortic stenosis, that's bad. In fact, most people who show this slide have probably never read the very original paper. That was not even a full-fledged research study. So I would say it's more like a kind of a review article. Now, when we talk about the evolution and revolutions in management, obviously, first, there was no remedy. There's nothing you can do about it before the heart surgery came along. Then the surgical aortic valve replacement. Then there was a period we thought balloon valvuloplasty will last, the effects will last forever. We realized it doesn't. But then fortunately, we have a transcatheter aortic valve replacement. This is a big deal. Instead of open heart surgery, we are able to achieve this almost the same results with a TAVR. And in fact, so far what we have learned in terms of follow-up of the patients, it's as good or even better than surgical aortic valve replacement. Now, let's talk about paradigm shifts. In terms of management, first, if it's a moderate aortic stenosis, you just medically follow them. Severe aortic stenosis plus symptoms, symptomatic severe aortic stenosis, today it's either TAVR or SAVR. TAVR, not in all patients, I will talk about it in a second, but both of them can be performed. It depends on the coexisting disorders. Moderate to severe aortic stenosis, it's not critical, but if the patient is undergoing some other cardiac surgery, then the aortic valve also is generally replaced. Severe aortic stenosis, no symptoms, asymptomatic severe AS, what to do has been controversial for many years. Now I think we are getting more and more information. And these are patients with severe AS, no symptoms. There's one trial recently from Asia that showed that the outlook is better with surgery. This is about surgery. How about transcatheter approach to asymptomatic patients with severe AS? There's a trial going on called EARLY trial, and it's not over yet. It's kind of difficult to enroll patients, but it's going on, and that will provide us some results. So everything then boils down to what is severe aortic stenosis and how do we assess that one? And first, we got to know what's the normal aortic valve area. This is a Caucasian population in US, and the numbers might be somewhat lesser in India. Basically, it could range in females anywhere from 2.4 to almost 5. And in men, it's a little bit larger. And that's what is generally a normal range, depending on the age and body size and so forth. You can correct for the body size, aortic valve area index, and it may help to some extent, but it's not the perfect alternative for that. Generally, it's considered 1 square centimeter or less is severe aortic stenosis. Now, this is a cutoff line that was drawn a long time ago and looking at the prognosis, but we have to remember they didn't study what happens 0.9, 0.8, 0.7, 1.1, 1.2, 1.3. There's a cutoff line that discriminated, so we shouldn't be slaves to this 1 square centimeter number. But we need to have some objective measures. So quantification of aortic stenosis is critical. We know that. Let's look at the evolving gold standards for aortic stenosis severity. First gold standard was a professor. This is before the days of echo. And if there is a thrill, left ventricular heave, attenuated or absent A2, and there is a late peaking murmur. There's a problem in everything. First, not a lot of patients have thrill. Maybe they're thin-bodied, and in India you might feel it more than, say, in the Western countries. Heave, maybe, but not always reliable. In many patients in America, I cannot even feel the apical impulse. Heart sounds, attenuated or absent, A2, maybe, but sometimes there could be a stenotic valve with one leaflet moving nicely and the other 2 cusps might be restricted. Then the sound may not necessarily be muffled. And the murmur, grade 3 or 4. And, when there was nothing else available, people graded 1 to 6. I think that is a pretty stupid classification. 1, 2, 3, 4, 5, 6. And the difference between 3 and 4 is the presence or absence of a thrill. So I'm happy we can identify a systolic murmur, and then you can try to get some more information. The late peaking, even in very severe aortic stenosis, the murmur is never late peaking. The maximum turbulence and maximum velocity at the most could be in a mid-systole. Late peaking murmurs appear only in, say, hypertrophic cardiomyopathy or, say, late systolic prolapse. Otherwise, in aortic stenosis, the maximum intensity in severe aortic stenosis would be mid-systolic. Then came the catheterization, Golden equation. And, Golden equation was never properly validated. And for mitral valve, it was designed for mitral valve, never really was properly validated. A few postmortem hearts and the surgeon feeling the valve in the operating room was a gold standard. And it was never validated in low flow states or high flow states. So we have to remember the issues. Now, echo, of course, continuity equation and other parameters. Continuity equation was validated against Golden equation, which is already a flawed index. So we have to remember any number that comes out of is not necessarily perfect Also, there are some other reasons why continuity equation might not give you the actual accurate valve area. Then there are other parameters. We'll talk about it in a second. And now, of course, we all combine CT along with echo, not only to do a planimetry, but also to look at calcium burden. So I just told you that these were not properly validated, and this was validated against this, and this has problems, as I mentioned. Now, let's talk about continuity equation. What we do here with a understanding, the amount of flow that goes through this is the same amount that comes out during systole. And to get the flow, we take the dimension of the LV outflow, assuming it's circular. We get nice pulse Doppler flow profile at that site and get the velocity time integral. We get the V2, the maximum velocity signal, and get a time integral, velocity time integral in that. So from this, we calculate the left ventricular outflow area. And this one gives us a velocity, so we can compute the stroke volume, if you will, or stroke flow going through that. And we know the distal velocity. And so aortic valve area is LV outflow area times time velocity integral, 1, divided by the maximum time velocity integral. But the problem is, this assumption is false, okay? In most patients, particularly as we start doing CT and all that, in most patients, this one underestimates the left ventricular outflow. If you do a CT, you look at this example, another example, you can see it's very often asymmetrical. This measurement, which corresponds to this particular orientation, very often underestimates the LV outflow, which means it'll underestimate the stroke volume, which means it'll underestimate the area. In other words, overestimate the severity. We have to keep that in mind. But nevertheless, it has some prognostic value that has been shown in many studies. How about the calcium? Assessing the calcium in a quantitative aspect is hard using echocardiography as it stands today. And the CT gives us some numbers. Basically, if this more than 2,000 Augustin units in males or 1,200 in females, that is consistent with severe AS. In almost all tower patients undergoing that, we get a calcium score besides looking at the LV outflow using the CT measurements. Now, we talked about the issues with the continuity equation we touched upon. One is this assumption is wrong. And you can do a 3D echo that would help to some extent in getting the LV outflow if the study quality is decent from transthoracic approaches. Location of the pulse wave Doppler sample volume is critically important. Too much into the left ventricle, you will underestimate. Farther into the LV outflow, it may be hard to get a good signal. And also, generally, we measure the V1 flow profile in some heartbeat, and we do the V2 in some other beat. It's not in the same beat, so we have to keep that. A lot of errors sometimes made is not getting a good pulse Doppler flow profile. It should be, one should try hard to decrease the sample volume size and get a crisp profile where there's a lot of dark area inside so that the flow would be somewhat laminar. If you move it close to the valve, there will be a spectral broadening. And from the maximum velocity profile, we get the velocity info from which we can calculate the peak gradient, 4V squared. And then we get a mean gradient, and then the dimensionless ratio, that is whatever the blood goes into the LV outflow, the VTI of that, and a maximum VTI. And one should also try to look at the flow rate. And there are suggestions that acceleration time and corrected for ejection time might be useful. Now, here is a pulse Doppler sample volume. Not too bad. I would have liked it to be a little more crisp. And in this example, pulse Doppler sample volume, the VTI is about 22. And the same patient here is a CW Doppler. We get a maximum velocity profile. But very often, if you do the CW Doppler carefully, don't use too much gain, one can actually bring in the V1 profile also. Profile within a profile. And if you use that one as V1, that's, we are talking about, we are doing the measurements in the same beat, a big advantage. Why then people never used it so far? There was a concern that as the sample volume goes close to the aortic valve, there's so much flow acceleration there, and it might artificially increase the VT1. But that concern is overstated. Okay. So if you can get the profile here nicely, better to use that. In this case, for example, let's see, it's somewhere here. This is 21.9, and the pulse Doppler, it was 22. Okay, so it's very close. And the advantage is the same beat. And again, as I pointed out, same beat. So try hard to bring out this kind of a profiles, profile within a profile in patients with aortic stenosis. Another thing we do, again, started from the cath lab. In atrial fibrillation, you have to average 3 or 5 beats, preferably 5 beats or more beats, because the flow volume changes from beat to beat. Then we said, most of the time, short cycle beat is not a good idea. It's going to decrease the flow. Long cycle, it's unlikely to dramatically increase the flow to more than way beyond the normal range. In fact, we looked at it in one study. Aortic valve area, long cycle beat, short cycle beat, you can see there's not enormous difference. So one of the advantages in atrial fib is you are using the same beat, and also you take the long cycle beat, and that gives you reliable information. One thing to pay attention is something called the flow rate. Okay, the flow rate data can be obtained in almost all instruments. It's there. You just activate it, make ejection time measurements. So it's basically corrected for the ejection time. That's the flow rate. Okay. Now, it does influence our calculations and so forth. For example, all this curve, this is a flow rate and is a pressure gradient. This is severe AS, this is mild AS. Let's take this moderate AS curve, the orange line. And you can see the flow rate is somewhere in the normal range. Then the pressure gradient is not high. It's about 25 or so. Same patient with moderate aortic stenosis, if we increase the flow rate by beating the ventricle hard, giving dobutamine, and then you can see, even though it's moderate aortic stenosis, the pressure gradient goes up here almost to 80. So flow rate influences the gradient, and therefore it's worth measuring it. If one uses low dose dobutamine to increase the flow, one got to look at the flow rate. You don't want to beat the ventricle too hard. Then there will be increase in the pressure gradient that may not reflect the true aortic valve stenosis severity. Another one is the acceleration time, and AT corrected for ET, okay? Which is, we all look at the profile, and basically, if it's severe aortic stenosis, the peak will come later. If it's mild or moderate, it'll come earlier. And that's what we are measuring from here to the peak velocity. That's acceleration time. Because flow and flow rate influence the gradients, one could correct it for the ejection time as well. And these are supposed to have, say, sensitivity and specificity in 70s range, sometimes 60. I look at the flow profile, but we don't make any of these measurements. And also the fact that if it's early, that goes against severe aortic stenosis may not be valid all the time. For example, if a patient has mitral regurgitation that's starting here, this velocity might fall, LV outflow velocity, or patient with a left bundle branch block, the timings might change. So I'm happy just looking at a profile and then interpreting it in the light of what else is going on, rather than just making a measurement and say, okay, this is severe, this is not so severe. One of the things we have emphasized for many years is the planimetry of the aortic valve. And here is mild or almost mild AS, moderate to severe, and severe AS. With the understanding, the fundamental problem in aortic stenosis is a reduction in the valve area. And if you can get it by planimetry, with careful planimetry at the tips, that's great. And TEE might give a nicer depiction of that at times. But even in transthoracic, for example, this is a good quality transthoracic imaging. This is not so great, but still one can, if you go frame by frame and you can identify the aortic valve area, this in a still frame, you don't know, but you actually play the video or go frame by frame, one can recognize. So in a vast majority of patients, you can get a planimetried aortic valve area by TEE. In more than 70%, one can get it by transthoracic short axis imaging. You have to kind of cut down the sector size, do everything possible to improve the image resolution. Another thing, a myth in my point of view that has been going on is valve area is flow dependent even in severe AS or a moderate AS, and that came from the kind of Golin equation approach. But, I have spent, even now I go to operating room 2 or 3 times a week, whenever they call me or if it's a difficult patient. I have personally felt the aortic valve area in patients with calcific AS going through surgery. Man, it's like a rock. And you wonder, how can it change with the flow? And that prompted us actually to do a study looking at this being the neutral. We reduce the flow, we increase the flow, basically the stroke volume, and looked at what happens to the aortic valve area. You can see in moderate and severe aortic stenosis, it doesn't change much. So I'm a big fan of the planimetry approach. And also this gentleman who was my fellow when we did the study, he repeated the study and he went back to Canada and compared it to the Golin equation. And he demonstrated that Golin equation derived aortic valve area changes with flow, but not a planimetry aortic valve area. So I recommend you rely on carefully perform. It has to be at the smallest area, usually at the tips. Another one is, I think the guidelines are evolving and changing, but generally severe aortic stenosis, you should have more than 40 millimeters of mercury gradient, mean gradient. But, later on, now everybody realizes you can have severe aortic stenosis, but the mean gradient might be lower than that. And in fact, 30 to 40% of patients with severe aortic stenosis will have a lower gradient, not necessarily more than 40. And there are various mechanisms for that. One well-known thing is LV dysfunction. EF is low, and the flow going into the aortic valve is low, and that can give you a low mean gradient. But you can actually do either planimetry or do a low-dose dobutamine and to increase the flow and recalculate the aortic valve area. That's one option, okay, to correct for low stroke volume due to systolic dysfunction. Planimetry or low-dose dobutamine. Now, this is a patient, dyspnea, and history of long-standing hypertension, peripheral artery disease, a lot of atherosclerosis, hypertensive. You can see the blood pressure here. EF is okay. And the valve area, is calcified, opening is limited. And because anywhere from 30 to 50% of patients with aortic stenosis have systemic hypertension, we have to keep that in mind. In the setting of systemic hypertension, where there's an increased afterload for the left ventricular ejection, and the gradient might be low. Aging, often atherosclerotic vessels, or the aortic compliance is lost, hypertension, all this can give you a higher global hemodynamic load, not only the valve level, but also the aortic level. So in dealing with the patients, we have to keep these things in mind of the role of increased vascular load. And then some ventricles, they are so small, okay, so small, they may not be able to put out an adequate stroke volume, even though overall cardiac output could be okay. That also is another reason for low gradient despite severe AS. And then we have the state, paradoxically low flow, low gradient, normally severe aortic stenosis, okay? Now, how we precisely assess this when the EF is normal and is still kind of still undergoing a lot of thinking and studies, and one can do a stress test, is it valid or not? It's still not fully, it's not a settled science yet. Here is another individual, there's aortic stenosis, high gradients, but the mean gradient is about 35 or so. But the reason in this case is a patient has amyloidosis, markedly elevated filling pressures. Okay, if the filling pressures in the left ventricle are highly elevated, it's going to restrict the flow coming into the LV, which subsequently will decrease the forward stroke volume. Filling dysfunction, restrictive physiology or constrictive physiology, basically mostly low volume, low flow rate. Coexisting mitral disease, okay, either severe mitral stenosis or mitral regurgitation. If there's significant mitral regurgitation, the forward stroke volume will be compromised because part of the blood goes into the LV. So in that scenario, the gradients could be low, and also the velocity profile might simulate moderate AS. We have to keep that in mind. Same issue with this stenotic mitral valve with a significant gradient. This can also lead to a low gradient scenario. Coexisting mitral valve disease. Significant right heart dysfunction. Could be RV dysfunction, could be severe tricuspid valve disease. They would also lead to decreased right-sided flow or stroke volume, which in turn would lead to a decrease in left ventricular stroke volume. So coexisting right heart disease. So all these different issues I talked about could lead to a low gradient. So don't get fooled by the low gradient, but they can be sorted out. Then there's another entity, which is the other side. Patient is asymptomatic, but the gradient is very high. Okay, in this patient, the maximum gradient is 140, mean gradient of almost 90. So you can consider them a critical AS, supercritical AS. In this kind of a patient, even if the patient is asymptomatic, I get concerned. Well, most people would intervene in that scenario. With all these different parameters, one has to not take any one number, but put all the things together, and when needed, take adjacent imaging techniques like CT. This is a nice review article. I recommend all of you read it by a bunch of experts on aortic stenosis, and Partho is somewhere there. Partho is one of the co-authors. It's a nice review article. And also we have to remember, AS might have some companions. The clinical picture might be dominated by aortic stenosis, but there could be a hypertrophic cardiomyopathy coexisting with aortic stenosis. If we don't recognize that one and just replace the aortic valve, we'll get into big problem. Okay, and because once you relieve the afterload by replacing the aortic valve, then the LV can go into a squeeze, a contracture. Sometimes it's called suicide ventricle. So every patient undergoing TAVR or SAVR, one got to make sure there is no LV outflow obstruction in a subvalvular level. And here is another patient. You can see aortic stenosis and also hypertrophic cardiomyopathy. And this is less common, but here what we have is aortic stenosis, little septal hypertrophy, and also some SAM. On top of that, this patient had a subaortic membrane as well. So again, I repeat, every patient undergoing an intervention for aortic valve, we have to look for possible subvalvular issues and be aware of that. So I thought I knew about aortic stenosis, but as years go by, you learn more and more, and I'm glad that we all are learning a lot. Thank you very much.
Hi, Ned. Good morning.
Hi.
You said that aortic valve planimetry is a very good tool to diagnose and quantify severity of aortic stenosis. But do we have data that aortic stenosis as quantified by planimetry is better than continuity equation?
In my point of view, yes. In my point of view, continuity equation very often underestimates the valve area. Okay, I'm not saying it's bad, because continuity equation derived aortic valve area has been shown to have prognostic value. So what one should do is not put too much weight on that, and do a planimetry also. You know, if the gradient is, like I showed you, the mean gradient 60, 70, I don't even care about the valve area. Okay, and but most cases we need to get some understanding, and so my suggestion would be to do a planimetry. And people think, I can't see the valve properly, but you have to concentrate. And if you do that, in majority of patients, you can get a valve area. If there is an error, 0.8, 0.9, who cares? Okay, all we want to identify is severe aortic stenosis. And I again want to say, even this 1 square centimeter or indexed valve area 0.6, it was not based on big scientific evidence. There's a cutoff line in the days of Golden equation, and that's how it derived. And another point I did not touch, what we call moderate aortic stenosis, let's say 1.1 or 1.2, you know, it may not be moderate in all patients. It may be, in terms of the number, it may be moderate, but it can give enough trouble to the patients and symptoms. So the definition of severe aortic stenosis should not be dependent on just one clear-cut cutoff number, because they are flawed.
But as far as planimetry is concerned, it is not that easy to do it on transthoracic echo. However, it will be relatively easier and more accurate on transesophageal.
Yeah, transesophageal is much easier. I agree with you. But that we asked that question actually once. Okay, what percent of patients? I said, what's the big deal about TA? It just gives better pictures. Why can't we do it transthoracic? And we systematically looked at it. And what we noted was, in about 75, actually it was 76% of the patients, it was possible to get a planimetry with a transthoracic, which correlated with a transesophageal derived area. And so in a majority of patients you can. Some obviously you cannot.
Yeah, so one more question. Should systemic vascular resistance be calculated in all cases of aortic stenosis?
Yes, you know, there's one parameter I didn't go into detail called ZIVA, that integrates the resistance and the flow, and you can calculate that one, although most people don't do it, regularly, and that gives an idea. But if I know, you look at us 80-year-old, 85-year-old, and had a history of hypertension for a long time, not fully controlled, and also atherosclerosis, I know it's going to be high. Yeah, and so, but you can calculate zero.
Very important question. When you have calcium on the aortic valve, planimetry is difficult in transthoracic. So any practical suggestions?
Yeah, well, that's the same question Mahesh asked also. And again, in the technical point of view, you try to do everything to improve the image quality. Small sector size. Don't zoom. A lot of people zoom this, magnify the image, and that doesn't necessarily improve the resolution. In fact, it increases the garbage into a bigger picture. Okay, so smaller sector size, right transducer frequency depending on the patient, and not too much gain, not too much optimal gain. And if you try, most people, who says it's very difficult, that's their impression. They have not actually tried to do it systematically. And if you try to do it systematically, you will find that in a good number of patients, you can get it. Again, I don't care whether it's 0.9 or 1, okay, or 1 or 1.5. And I'm not a big believer in this drawing a line at 1, okay, because we have to put many things together.
Yeah, so I think this solves the next question. The question was, if aortic valve area by planimetry is 0.8 and by continuity is 1.1, what should we believe, especially in low gradient aortic stenosis?
Okay, usually it will be the other way around, where the continuity equation derived valve area would be smaller than the planimetry valve area. In those kind of scenarios, again, I will rely more on planimetry valve area, provided it's done properly. Second, again, it's worth emphasizing, look at all the other pictures. How does a valve look? How much calcium in there? So look at all that and put it together.
This is good for degenerative calcific aortic stenosis. What about bicuspid aortic valve? Can we do a good planimetry also?
Yeah, bicuspid aortic valve, if it's highly calcified and all that, and the opening is restricted, is not that much of a problem. On the other hand, if there is no calcium, it's not stiff, it's a pliable valve, but tight narrowing, the opening could be eccentric. It's so if you do with a TE or with a transthoracic, that could lead to problem. In that scenario, even other scenarios, but particularly in that scenario, 3D imaging would be helpful, because then you can alter the short axis cut at the tip of the aortic valve.
Great lecture, Dr. Nat. Thank you so much. It is amazing to have you.
Yeah, but you woke me up. I got to get up at 3 o'clock in California.
Thank you so much. It has been amazing.
And you don't give a drink, you don't give food, nothing. Okay.
So I think for that we will have our Brazilian colleague, Brazilian friend, Dr. Marcelo, who is joining us from...
Hi, Marcelo.
Hi, Marcelo. Can you unmute him?
Nat, we owe you a drink. When you come to Nagpur next time, we will definitely have a good drink.
Good. Don't ask me about our paper. It'll come. It's coming. Okay.
Nat, it's absolutely great to hear from you. It's almost like I've been 15 years ago in our Echo Lab in Tufts University. That was fantastic.
Yeah, we had the fortune of having Marcelo spend part of the year with us. So we learned, and now I'm proud to see him as a dominant leader.
On the contrary, it is absolutely graceful from you. It is really absolutely great to hear from you. You have the same power, the same energy as 15 years ago. That is fantastic. You have made my day. Fantastic.
Oh, it's always nice to hear compliments. Give some to Sunil too, poor guy.
Okay, absolutely. Hi, Sunil.
So can you
Bye-bye.
unmute Sunil? Yeah.
Thank you, and great to see you, Marcelo and Nat. It was great listening in. Always learn from the master, my sensei, and it's great to be part of the meeting with such prestigious people.
Yeah, I think we are fortunate to have the leaders in the field of echo. Thank you so much, everyone. So let me have Dr. Marcelo. He is live from Brazil, Sao Paulo, and he is a professor of cardiovascular medicine at the university in Sao Paulo, and also the president of the Brazilian Society of Cardiology. Marcelo, can you share the slides, please? And he's going to talk on EMF.
Yeah, absolutely. In a few seconds.
Attends. Faut qu'il l'attende.
So that is the place of Pele and Maradona. Maradona was from Argentina.
Présentation.
I'm going to full screen.
Yeah.
Okay, yeah.
That's good.
That's good. Can you make it full screen?
Yeah, it is going. It's loading. See, Shantanu, it was also fantastic to hear Luigi. That's a fantastic guy.
Yeah.
Have you the full screen?
Yes,
Yeah.
you're on.
Yeah. See, as Nat said, here in Brazil, we're almost like 10 o'clock in the morning, the middle of the morning. This is fantastic because you are almost like 8 hours and a half ahead from us. I believe that it's 9 hours and a half ahead from Nat. So, Shantanu, I'd like to deeply thank the organizing committee as yourself for such a wonderful opportunity of being with so many friends from different continents and to talk a little bit about very rare situations like endomyocardial fibrosis. I think that on behalf of Ricardo Pinatelli, who comes to be the president of the CCAC, the International Cardiovascular Imaging, from the from the Inter-American Society of Cardiology, as well as from Carlos Rochidi, who comes to be the president of the Brazilian Department of Cardiovascular Imaging, as well as from Marcelo Queiroca, which comes to be the president of our society, Brazilian Society of Cardiology. So it's a big pleasure and honor to be with you today. So we're going to talk a little bit about a patient, a 63-year-old female patient from an area in Brazil, endemic for Chagas heart disease. In fact, she was referred for the cardiology evaluation after an ischemic stroke. Patient was absolutely asymptomatic, and the diagnosis of the chronic phase of Chagas disease was suspected most based on EKG and echo findings. And it was confirmed by the antibody detection using two tests, as usual, the indirect immunofluorescence and chemoluminescence. It was infection by the protozoan Trypanosoma cruzi, which comes to be endemic in South America and Central America. The EKG showed sinus rhythm as well as RBBB, and left anterior M block, which are absolutely common concerning Chagas heart disease. On Holter monitoring, the patient also presented several episodes of known SVT, and there was no heart blockage. Here we can most beautifully observe the TTE. Let's see if it runs. Okay, it's running. You can see the function, the biventricular function was preserved, but we have some sort, as you can see in that here, in the right apical segment, there was some sort of hyperreferency and also some sort of deposition. Once again, let's see in white in here from the right ventricle, the apical right ventricle, as well as in the left ventricle, left apical segment. On 3D TT, also we can beautifully observe this dense, perhaps fibrotic tissue over here. From the strain, we can observe that there was some sort of decreasing of the longitudinal strain concerning the medial and the basal segments of the lateral wall. Going ahead, to MRI, we can most beautifully observe that was some late gadolinium enhancement with heterogeneous pattern in lateral wall segments and a distinct homogeneous pattern, most or exclusively endomyocardial, with biventricular apex involvement associated with dark areas, most representing the thrombi formation and the thrombus formation. And we can most beautifully see and observe here. In here, we're going to observe the ventriculography and also coronarography, observing that there was no obstruction concerning the coronary arteries. And also there was some sort of very interesting apical obliteration or amputation of the apical apex, as we can see here net in zoom. Can we just observe the apical obliteration of the left ventricular apex? Once again in zoom, let's see if it runs. All right. Can you just see the obliteration of the apical segment of the left ventricular segment? So it concerns a very rare association of endomyocardial fibrosis in a patient with Chagas heart disease. It is a case from Professor Viviane Tiemiotta and Professor Charles Mad from our university in Brazil. And it's very interesting because this case will illustrate a very rare association of two very uncommon diseases, mainly for you in the US and Europe and mainly perhaps in India, and also reinforce the value of using new techniques for the proper diagnosis of this very unusual association, endomyocardial fibrosis and Chagas heart disease in the same patients. We have so many different presentations of cardiomyopathy, as we can see in the dilated cardiomyopathy as well as in the hypertrophic cardiomyopathy with different features. And here is an example from endomyocardial fibrosis, the restrictive cardiomyopathy, with very enlarged, for instance, atrium, right atrium and left ventricle. As a background, we can observe that the endomyocardial fibrosis is a very interesting form of restrictive cardiomyopathy, in which there is dense fibrous tissue in the endocardium, which comes to restrict the ventricular diastolic, mainly both ventricles, and distorts the papillary muscles of the atrioventricular valves. Endomyocardial fibrosis occurs primarily in tropical and subtropical areas worldwide. We're going to see that it mainly occurred in Africa. And it was first described in Uganda in 1946 by a pathologist, Jack N. Davis. It was subsequently reported in many different countries, in Kenya, Tanzania, Mozambique, Gabon, Congo, Cameroon, Sudan, South Sudan, as well as Sudan, Nigeria, Cote d'Ivoire, and Ghana. It is very uncommon in Northern and Southern Africa, as we're going to see later. Can we see this? It's very interesting. This is the map of Africa. We have two different red lines, and the endomyocardial fibrosis, it seems to occur in between those red lines. This is very interesting. So we're going to have most of the case in Uganda, in Kenya, in Tanzania, in Mozambique, also in Congo, in Sudan, and in South Sudan. This is very interesting. Here we have the map of Mozambique, and we have a very interesting study from Professor Ana Alba Mokumbi from Mozambique. This is a very, very, very important report describing very entirely what occurs with endomyocardial fibrosis patients. Today, we can observe that endomyocardial fibrosis is the most frequent restrictive cardiomyopathy worldwide, affecting over more than 12 million people in the world. It is said to be the most common form of heart disease in Uganda, where it accounts for nearly 20% of cases referred to an echo service. In Inahim, an account from Mozambique, it is a county for Mozambique in a sample of almost like 1,000 patients aged between 4 and 45 years old, the prevalence comes to be nearly 90%, what is very, very important. So it is characterized by the fibrotic tissue deposition in the endocardium of the inflow tract and apex of one of both ventricles. It can be related to the left or to right ventricle or to biventricular involvement. The morphology of the ventricle is usually distorted with normal or reduced volumes, whereas atrial volumes are absolutely increased. Because this is very important, the etiology of endomyocardial fibrosis is still now 6 years after the first report unknown. However, there is an early phase of hypereosinophilia, which can play a role in its pathogenesis. The diastolic dysfunction may be responsible for the severe heart failure. And the endomyocardial fibrosis plays a very important role in determining the exercise limitations. We can observe many factors which can be associated with the pathogenesis of the endomyocardial fibrosis in Africa. For instance, ethnicity in Uganda, it comes to be more common, and also from immigrants from Rwanda and Burundi. Poverty, the diet, age and sex is a little bit controversial. Thinking about sex, eosinophilia and infection can be some sort of relationship in between endomyocardial fibrosis occurrence and trypanosoma cruzi and Plasmodium falciparum. See malaria or microfilaria in Nigeria and Chagas heart disease in Rwanda. And also you can observe some sort of hyperimmune malaria splenomegaly. Endomyocardial fibrosis can predominate in children and in young adults with a peak incidence at the age of 11 to 15 in both sexes. Women can show a second peak between 26 and 30 years. We can have some sort of female preponderance in Uganda, but this is not observed in Nigeria. And this, some investigators have found no sex difference. And in some patients, there is some male preponderance from 2 to 1. There is some different hypotheses of the etiology of endomyocardial fibrosis. One of them is related to the prolonged ingestion of some sort of tuber, cassava, tapioca, crops, associated with the extreme deprivation of protein, which can cause endomyocardial fibrosis, and this hypothesis could be tested in an animal model with monkeys. You see, a control experiment showed that monkeys fed with an uncooked cassava diet compared with those on an uncooked banana diet developed heart failure and histological changes that are similar to those in the human disease. This study perhaps shows that the disease can be induced experimentally in the monkey, thereby providing some support of the high cassava, low protein diet hypothesis. But there are some other hypotheses for the disease. You see, we can observe that eosinophilia is also being proposed as a major risk factor for endomyocardial fibrosis in both East and West Africa. You see that the level of eosinophilia has been found to be inversely related to the duration of illness, leading to the concept that the patients who do not have eosinophilia are at a late stage of endomyocardial fibrosis. Perhaps this could be one of the most beginning stages of the disease. In fact, a few cases diagnosed in the acute thrombotic phase, another phase, the very beginning phase of the disease, which comes to be the first clinical phase before the development of the scar, show in fact hypereosinophilia. This has led to the suggestion that leaflet endocarditis and endomyocardial fibrosis could represent the extremes of the same disease. This is very interesting. And also you can observe that eosinophils can be, in fact, toxic to also, not only to the endocardium, but also to the myocardium, resulting in neurothrombosis and fibrosis. Here we can observe the number of publications in PubMed concerning the 50s and also to the first years of the 21st century. We could observe here from 19 papers from the 50s to 60s, going to 83, 98, 98, 149, and going down to 88 on the 90s. And also here we can observe that in this chart, the distribution by country of published case of endomyocardial fibrosis in between the 50s and the first years of the 21st century. We can see here, for instance, in red, Uganda. We can have here Mozambique. Here we have a specific state of Brazil, which comes to be São Paulo. In here we have Bahia. Net know very well those two states from Brazil. As clinical features of the endomyocardial fibrosis, they will depend on the state of the disease and the anatomic involvement of the heart. You see that 30 to 50% of children and adolescents report an initial illness with fever, chills, night sweats, facing swelling, and urticaria. This illness may disappear, or it may lead to rapid development cardiac failure and early death, and it may involve both left ventricle, right ventricle, or biventricular involvement, leading to heart failure. So unlike congestive heart failure, the ascites is an exudate in 75% of the case. It is associated with peritoneal fibrosis. An exudate pericardial effusion is a common presentation. It is suggested to be a systemic inflammatory disease, which has been called the endomyocardial syndrome, and the prognosis is poor in this condition, and therefore usually occurs within 2 years of the diagnosis. It is a very deadly situation. And here we can observe a patient, fortunately with some sort of endomyocardial fibrosis. The site with little of no peripheral edema. It comes to be characteristic and a clinical characteristic feature regardless of which ventricle is involved. So it's a very interesting disease. And this chest ray, we can observe a patient with a very advanced biventricular involvement, a very large biventricular situation. Echo, for instance, for sure, is the first line and the gold standard non-invasive technique for the diagnosis of endomyocardial fibrosis. It enables the identification of the disease in the early stages and the quantification of the morphological and hemodynamic compromise, and the assessment of change over time with surgery. We can see the involvement of the apical areas, the segments almost like the right ventricle and the left ventricle, atrioventricular insufficiency, as well as pericardial effusion and so far. However, echo may sometimes not very well characterize the free fibrotic tissue, and it may not fully differentiate endomyocardial from any other cardiac situations, which can come to have apical obliteration, such as in apical hypertrophic cardiomyopathy, some sort of cardiac tumors, apical thrombus, non-compaction of the left ventricular myocardium. And in patients with predominantly right ventricular involvement, the differential diagnosis includes for sure Epstein anomaly and also constrictive pericarditis. We can hear most beautifully from a paper from Professor Vera Salemi, also from my university, from the team of Professor Charles Matt. We can most beautifully observe, for instance, the left ventricular endomyocardial involvement. Let's come back a little bit. In here, the arrows, and here the right ventricular involvement, also once again the apical involvement, and here we have the biventricular involvement, almost like the obliteration and amputation of the left ventricular apex and also the right ventricular apex. And in here, one very important differential diagnosis concerning the hypertrophic apical cardiomyopathy or medium to apical cardiomyopathy. From the ventriculography, for instance, we can observe the right ventricular endomyocardial fibrosis, the amputation, and also the obliteration of the right ventricular apex, and we can really observe in here. In fact, the contrast ventriculography was at first considered to be the gold standard methodology for the diagnosis, but today with improvement in the echo, And also the MRI, it is no longer routinely performed. In here, we can observe once again the amputation and the obliteration of the left ventricular apex. And also you can see, in addition to its risk, the biopsy allows the diagnosis in just only about 50% of the patients. So we're going to see later, we can have today a risk score and also a diagnostic score that can lead to the real diagnosis. From this paper from Professor Vera Salemi, you can observe concerning patients coming from functional class 1 to 4, we can observe the relationship in between the fibrotic tissue volume over the blood surface area. Can you observe here? We can have, for instance, the ratio going from 3.2 to more than 7 times 21.4, 7 times more in patients in class 4. And also patients that went to surgery approach, we can observe more than double the relationship, this ratio between the fibrotic tissue over the blood surface area. Patients that went to surgery had more than double the ratio of the fibrotic tissue volume in relation to the blood surface area compared to patients that had clinical follow-up. Also, we can hear from the pathology, you can just beautifully see here what characterizes the endomyofibrosis, which comes to be the tissue, the fibrotic tissue deposition also in the endocardium of the inflow tract, as well as in the apex of 1 or 2 both ventricles. We can observe here, we can characterize and see how important it is, the differential diagnosis of hypertrophic cardiomyopathy. We can here observe the fibrotic tissue deposition in the endocardium, also in the inflow tract in the apex of 1 of both ventricles. And also in the valvular apparatus and the cord, it can lead to atrioventricular valve regurgitation. We can observe that they're going to see later. This is very important to the surgical approach that we have to treat this sort of pathology. And also from histology, you can most beautifully observe the fibrotic tissue deposition in very different organs. See, as I was talking before, this paper, this manuscript from Professor Ana Olga Mokumbi from Mozambique, from a rural area of Mozambique. It was reported some criteria for the diagnosis and assessment of the severity of endomyocardial fibrosis, as we had, for instance, in the infective endocarditis, or for instance, in rheumatic heart disease, we have some major criteria and some minor criteria. For instance, as major criteria, we have the obliteration of the right ventricle or the left ventricle apex, the presence or the evidence of thrombi or spontaneous contrast without severe dysfunction, ventricular dysfunction, and also the retraction of the right ventricular apex, as we can have as major criteria. To a definite diagnosis of endomyocardial fibrosis, it is made in the presence of 2 major criteria or 1 major criterion and plus 2 minor criteria. To our score up to 8, we have mild endomyocardial fibrosis. From 8 to 15, we have a moderate disease. And over 15, we would have a very severe endomyocardial fibrosis. So this chart with this criteria is absolutely important, is a very relevant contribution of this group from Mozambique. From Brazil also, we've been studying endomyocardial fibrosis from the 80s and from the 90s, and we have some very important contributions. This is from the group of Professor Pereira Barreto and from Professor Fulvio Pelegi, Professor Adib Jatene, Professor Sérgio de Oliveira, Professor Protásio da Luz, Professor Noedir Stoff. And we had some curves analyzing the factors that could have some very important influence concerning the course of endomyocardial fibrosis follow-up. And they have shown that the biventricular involvement, moderate or severe, and the right ventricular fibrosis and the evidence of a tricuspid or mitral regurgitation were very tightly associated with greater mortality. As you can observe in this chart, we can observe the survival curve, for instance, the involvement of left ventricular involvement. For instance, in severe, we can observe in red, as well as from the right ventricular involvement. From the very beginning, the right ventricular involvement is associated with a very poor survival curve concerning the follow-up of those patients. And also, we can observe from the mitral, the presence of mitral regurgitation with a poor survival rate, as well as from the tricuspid regurgitation. So, right ventricular involvement, biventricular involvement, left ventricular involvement, mitral regurg, and tricuspid regurg, they were all associated with poor survival. And this perhaps is a very important chart from a paper from our former professor from cardiothoracic surgery, Professor Sérgio Almeida de Oliveira, a very, very important professor from cardiothoracic field from Brazil and from Latin America. And this is a presentation of a strategy of his approach to treat endomyocardial fibrosis. He has worked with many professors from Brazil, Luiz Dalan, Luiz Lisboa. Today, Dr. Marco Antonio Praça and Dr. Gustavo, they have worked for many years concerning endomyocardial fibrosis patients. And we can observe from the start the dissection from the apex of the left to the left ventricular base from approximately 3 centimeters, and then the section to expose the ventricular cavity. What is very interesting in this approach, that is going to preserve the atrioventricular valves. They are not going to change into two different prostheses, and to mitral and to tricuspid prosthesis. This is very unique to undertake a valvuloplasty concerning the mitral and the tricuspid valve. And also after that, the dissection of the fibrosis to maintain the mitral valve apparatus. As well, we can see, he's going to take out of the left ventricle the fibrotic tissue as well as thrombi. Once again, in ZoomNet for you, this is just for you, can observe the fibrotic tissue, and also they're going to take out this huge amount of fibrotic tissue as in Zoom. Once again, can observe a very important restrictive sort of cardiomyopathy, and also so many different thrombi that were taken from the right and the left ventricle apex. And also to his technique from Professor Sérgio, some sort of valvuloplasty. In this case, the Vegas tricuspid valvuloplasty, as well as doing the same thing, not with the Vegas, but that a sort of technique to treat a mitral valve. Here we have the resection of right ventricular endomyocardial fibrosis through the tricuspid valve, maintaining the integrity of the papillary muscles and the cord in the suture of the apex. This is very interesting, and comparing to the classical approach, which was to change to replace the mitral and the tricuspid valve, we can observe in green that his approach led to a greater survival in those patients with class 3 and 4 New York Heart Association. And we could say that till today, in the 21st century, the endomyocardial fibrosis is still a mystery after 60 years, and despite several hypotheses regarding the cause, no account of the etiology of the disease has yet fully explained its unique geographical distribution. And you can see in this case, we had a combination of endomyocardial fibrosis and Chagas heart disease. I have to say, Shantanu, just 1 or 2 words on the Chagas heart disease. As we can observe, Chagas heart disease is a chronic systemic parasitic infection caused by a protozoan Trypanosoma purus. It was first reported in 1990. We have some vectors It comes to be some bugs, blood-sucking bugs of the subfamily Triatomy. Carlos Chagas from Brazil was the first to report this sort of the pathology. And this report is unique, very, very, very unique in the history of medicine, because at that time, he has described not only the biological characteristics of the factor and the parasite, but also the trypanosoma cruzi reservoirs, the disease clinical presentation and evolution, the diagnostic methods, and the possible treatment options. He had some very important contributions from Professor Salvador Maza from Argentina and from Professor Rodolfo Talis from Uruguay. Can you just observe here, we had in Rio de Janeiro in 1897. Can you see that? Here in 1897, on the other side, on the right side of the chart of the picture, we have some sort of patients from the county in Brazil, Laçãs, a city, in a very typical rural home area with mud walls and grass or straw-thatched roof. Can you just see the difference? And we can see, observe here, the life cycle of the trypanosoma cruzi, one sort of the patients of that period. He had a very important goiter. It was thought to be that it was due from Chagas heart disease, but in fact, it was from the scarcity of iodine in food. And we can observe here from the right, the histological sections indicating the presence of trypanosoma cruzi in tissues. You see, Carlos Chagas was very known at his time. In fact, he was nominated twice for the Nobel Prize, but unfortunately did not win. And at that time, in 1925, he was receiving Albert Einstein on his visit to the Oswaldo Cruz Institute in Rio de Janeiro. He was such a guy. You see, from the epidemiology, the transmission is in fact done by a vectorial mechanism from very different bugs, and we have non-vectorial mechanisms, for instance, blood transfusion, congenital transfusion, organ transplantation, ingestion of contaminated food, raw meat or liquid, such sugar cane juice or acai fruit, which is from the area of Amazon. As epidemiology, it is endemic in many countries. For instance, in South America, in Brazil, Venezuela, Panama, Colombia, Ecuador, Peru, Bolivia, Paraguay, and Chile, and Central America, and we have today in some sort of countries from Europe due to immigration from South America and Central America to Europe, as well as in US. This is a very important paper from Professor Harry Aquatella, one of the big guys in this field. He has researched in Chagas heart disease for more than 50 years. This is a recommendation paper for the use of multimodality imaging in Chagas heart disease, which was a very interesting collaboration work from the Inter-American Association of ECHO, ECHO-SIAC, and DIC, Brazilian Imaging Department of the Brazilian Society of ECHO. This is from a paper from Harry Aquatella. Can you see from 1965, the American Journal of Cardiology, a sweep from the basis of the left ventricle until the apical segment. This is very nice. And we can see from coronary heart disease, you can have sometimes a sort of apical aneurysm, but from Chagas heart disease, we have some sort of digitiform presentation. And we can see here from Professor Daniela Rassi and from Professor Salvador Rassi from Goiás, Brazil, a very interesting case with a thrombus presentation and an apical aneurysm, as well as observed most beautifully from her work in the 3D presentation, as well as the ejection fraction of this sort of patient. It is in the second edition of the CCIAC book from the CCIAC organization. And here we have from artificial intelligence, the same thing. And this is perhaps the most important paper ever on Chagas heart disease. It comes to bring the risk score for predicting death in Chagas heart disease. We have some risk factors as the class, functional class 3 and 4, cardiomegaly on X-ray, segmental presence and evidence of segmental global wall motion anomalies on 2D echo, non-sustained, non-SVT on Holter, low QRS voltage to represent pericardial effusion and the male sex. We have some points, and we can predict the total mortality in 5 years or in 10 years, dividing the patients into low-risk patients, intermediate risk patients, and high-risk patients. Can you just observe the mortality in 5 years whenever they are in the rise risk division? It is almost like 62% and 84% in 10 years. This is a very important paper from Anis Ras and the family Ras from Brazil, and Professor Mauricio Canavaca as well as from Brazil. And today, this is one or two last slides. We can just use and have to use, in fact, MRI just to make the composition and to evaluate the volume of the fibrotic tissue over the patients. And we can see this is a very interesting phrase from Carlos Chagas. This is a guy, can you just remember, we are in 1909. He had just a brilliant mind, his clinical observations in a tiny microscope. And he used to say that teach through research and research through teaching. This is very important. And we have today very young people working to overcome this, to overcome the COVID pandemic, as we have people from Brazil, from Japan, from Asia, from US, from China, from India, from working all together to overcome this very, very hard time that we have today and this pandemic time span. Thank you so much, Shantanu. Back to you.
A nice review about a disease which we hardly see in this part of the country. But I think we do see EMF in southern part of India. And I remember Dr. Vijay Raghavan, who is a senior cardiologist and teachers of teachers, has presented a lot. I'm sure Dr. J.C. Mohan has also joined. He had also shown us a lot of cases. Dr. Mohan, you are there. Can you unmute? We have seen a lot of EMF.
Hi, Professor Moran.
Excellent talk. Actually, we don't see Chagas disease at all. So we read it in, we were taught this thing as an undergraduate student. And after that, only when we come to ASC meetings, we hear about Chagas disease.
Fortunately, Professor Moran. What is very nice.
Yeah. But we have a tropical disease resembling this endomyocardial fibrosis, which is going down remarkably. But you continue to see sporadic cases. It's actually much less than what it was 30, 40 years back. And Dr. Vijay Raghavan published a lot of work, but now, of course, we don't see it that often. We do end up seeing maybe 2-3 cases a year.
Right. So
good, excellent.
Yeah, great talk. Thank you so much.
Thank you so much,
Dr. Marcelo. We are slightly behind schedule, so if I can request Dr. Sunil Mankar to share his presentation on unusual cases of systolic heart failure. Dr. Sunil, please. Yeah, we can see you. Unmute, please.
Fantastic. Great lecture, Marcelo, and I'll continue on. And over the next 20 minutes or so, I'm going to cover the topic of just some unusual causes of systolic heart failure. And I have no disclosures, but I think it's time for a joke, don't you? Let's show this important video here. Hopefully the sound works. The importance of a low-salt diet. All right, we'll continue on. Just for the purposes of information, and I think they're recording this presentation, so you'll have these references available. But the last guideline update actually for heart failure and the management was in 2005 by the ACCAHA. And there are 3 fundamental things that they need to know, and this is important for us echocardiographers. The heart failure doctors want to know what the LV ejection fraction is, and more specifically, is it preserved or reduced? And is the structure of the LV normal or abnormal? And are there other structural abnormalities such as mitral regurgitation? And Whenever possible, we should try to quantify the ejection fraction, measurement of LV dimensions and volumes. We should try to quantify the wall thickness, the chamber geometry, and regional wall motion, because these can be very important in determining the etiology of the systolic heart failure. The WHO classification is listed here, and they break down a heart failure into a dilated type with an LV systolic dysfunction and enlarged LV, a hypertrophic type, a restrictive type, arrhythmogenic RV dysplasia. But truthfully, they're going away from this term RV because it turns out arrhythmogenic cardiomyopathy affects the LV as well, and then unclassified. All right, let's just start in with the cases. This is the most common genetic cause of a cardiomyopathy. It is still an unusual cause, but in patients that have a family history of another member that had a dilated cardiomyopathy, we definitely need to check the genetics for the Titin gene mutation. The Titin gene is like some kind of a spring that helps the LV contract and relax. But when it's abnormal, you can develop dilated cardiomyopathy. And it is the most common genetic cardiomyopathy that exists. And this is an example of a dilated cardiomyopathy from the Titin gene mutation. So get a good history, because if other family members have had it, we should do the genetic testing for it. Now here is probably the most common dilated cardiomyopathy, an ischemic cardiomyopathy. You can see the regional wall motion abnormality in the inferior posterior wall. The heart is quite dilated. You see tenting of the mitral leaflets. In fact, there's quite restricted leaflet mobility of the posterior leaflet, and therefore it's no surprise when we put on color Doppler that there's severe functional mitral regurgitation. And that's a very ominous prognosis. Even moderate mitral regurgitation carries with it bad prognosis in the setting of an ischemic cardiomyopathy. But the key is here on echo is that we see regional wall motion abnormalities in addition to the dilated left ventricle. And the regional wall motion abnormalities fit the distribution of the coronary anatomy. That's really the key. All right, now this is an unusual cause of a dilated cardiomyopathy, but it's something that we should recognize because it's not as uncommon as we once thought. And this is left ventricular non-compaction. You see all this area here is non-compacted myocardium here at the apex. You see these deep trabeculations and recesses that are present here. Once again, I apologize. This is the Mayo Clinic format, so this is the left ventricle here, mitral valve, left atrium. But it's this non-compacted myocardium with prominent trabeculations that's really the key. And this is indeed, it's called spongy myocardium. It results from an arrest in normal endomyocardial embryogenesis. There's both isolated non-compaction, also associated with other congenital abnormalities. The RV is involved in a little less than half the cases. Now, echo is really the key to the diagnosis. Deep sinusoids, multiple prominent ventricular trabeculations. As I'll show you, contrast can be helpful. These intratrabecular recesses communicating with the LV cavity, and color Doppler can be very helpful too. And as I said, it's not as uncommon as you think. 0.05% of adult TEs in a recent series. So, that's not that uncommon, but we should look for it though. That's the important thing. Now, color Doppler can be very helpful. Clearly, we see here these deep trabeculations and sinusoids, but then we can put color on and see that they're real, there's no artifact involved, and color Doppler can be very, very helpful. Contrast echo can be very helpful too. This was a young man that basically just had some PVCs, and his LVEF is actually pretty well preserved in this particular case, although his heart's a little dilated. But you see these deep sinusoidal recesses that are present here. And that's really the key to the diagnosis. And contrast echo can be very, very helpful in identifying LV non-compaction. Now, 3D echo can be helpful too. This is just an example. We probably could make the diagnosis by 2D echo, but when we put 3D echo on, we really see that quote-unquote spongy myocardium that was shown in that pathologic specimen by Dr. Stolberger and his group that I showed you earlier. Now, there is this Jenny criteria that we usually use in echo, and there are a variety of criteria that you can use. This is one that I'm particular because it's easy to remember. At end systole, if the ratio of non-compacted to compacted myocardium, so in other words, at end systole, we could freeze the short axis image, we could measure the non-compacted myocardium and look at the compacted myocardium, and if it's 2 to 1 or greater, we would say this fulfills echo criteria for non-compaction. Cardiac MRI, which is probably a better technique to diagnose it, they have different criteria, just so you understand that, but the Jenny criteria is one of the criteria that we do utilize. As far as treatment, we treat heart failure just like we would any other cardiomyopathy. We have to screen for arrhythmias and consider early ICD placement, especially if they have LV dysfunction. Consider anticoagulation. There's probably not a procoagulant effect of non-compaction itself. It's just simply there's these deep sinusoids, and if you have LV dysfunction, there's stagnant flow, and a thrombus can easily form. And we need to screen relatives for this disease. Now, this is from my sensei, Dr. Pandian, just showing us by 2D echo an example of a thrombus right here in the LV apex. But I want you to see, look at the importance of 3D echo in this case. And when Dr. Pandian put on the 3D echo, I think you can appreciate the thrombus even better by 3D echo than you can by the 2D echo. But thrombus does occur, and when you have LV dysfunction, you should have a very low threshold to anticoagulate. All right, we'll move on to another unusual cause of heart failure. This was a 60-year-old male farmer in Minnesota who's referred for evaluation of dyspnea. He has class 3 heart failure symptoms, has diabetes, abnormal LFTs, bronze skin, and an S3 gallop. His vitals were unremarkable. But the key here is diabetes, bronze skin, abnormal LFTs. His EKG really just showed a left bundle branch block, or perhaps just an intraventricular conduction delay. If you're a purist, you might not call it a left bundle. His chest X-ray showed a little bit of cardiomegaly. And then we do the echo. And the echo shows a global cardiomyopathy. Probably severe LV dysfunction, below 30%, ejection fraction, probably in the 20% range, 20 to 25. Of course, anytime you have LV dysfunction, you got to consider coronary disease, even if it's global, but he did not have any significant epicardial coronary artery disease. We did a cardiac MRI, and the MRI, now the cine images really don't add anything to the echo. It's very clear that this is a global cardiomyopathy, the EF, once again, in the 20% range. But the echo showed us the same thing. Interestingly, though, there's no delayed hyperenhancement in this particular rare cause of heart failure. But what MRI can do that echo cannot is this T2 relaxation sequencing. So they put a region of interest on the heart, they put a region of interest on the liver, and they do something called the T2 relaxation time. And if they do that and it's prolonged, it suggests the diagnosis that is occurring in this patient with diabetes, bronze skin, and diabetes mellitus. It helps us make the diagnosis. And abnormal LFTs, of course. This is hemochromatosis, and you can see this patient with a very severe cardiomyopathy, a different patient. There's increased total body iron, intracellular deposits in the heart, liver, pituitary, pancreas, gonads, and skin, meaning almost every organ. Think of this when it occurs in the setting of hepatic dysfunction, diabetes, and tanned or bronze skin. The diagnosis is crucial because this is a reversible cause of cardiomyopathy. Males are affected 9 to 1. It's a rare disease. Ferritin is usually high. Wall thickness is normal, but they can have arrhythmias. And this is a nice pathologic specimen from Dr. Edwards at our institution, showing us how the iron is directly toxic to the myocytes. Now, this was a young man, a 26-year-old, who came to me in the CCU after a TIA. And as you can see, he has a global cardiomyopathy. This is the Mayo Clinic format, left ventricle here. And he's got a big thrombus at the LV apex. So severe LV dysfunction, a thrombus at the apex, but we make the diagnosis of hemochromatosis. We make it either by the basis of MRI or blood tests or a clinical suspicion in some cases, but usually MRI or blood testing, and we treat him. Of course, we anticoagulate as well. After treatment, about a month of deferoxamine, His EF is now nearly normal, as you can see here, and the thrombus is resolved. Because we made the diagnosis of hemochromatosis, we could treat it and reverse this cardiomyopathy. A few take-home points. Iron is very strong. We think of iron as strong and tough, but the iron heart is a weak heart. Hemochromatosis may be a cause of idiopathic dilated cardiomyopathy, and it's reversible. Cardiac MRI is pivotal to the diagnosis, and it can establish whether the treatment you're giving is working or not. So your radiologist or cardiac MRI cardiologist can follow how you're doing with the treatment you're giving him based on this T2 relaxation time. All right, a couple more cases and we'll close out. This is an interesting case that I saw in the CCU, a 53-year-old woman that presents in cardiogenic shock and heart failure. But she has a 2-year history of palpitations, sweating, and headaches. In fact, when she's admitted, despite being in shock, she's hypertensive and tachycardic, and she's transferred to our unit. Here's her EKG, just really sinus tachycardia, I think non-specific STT changes. Here's her X-ray. It shows heart failure. As you can see, she's intubated with an endotracheal tube. There's a little bit of cardiomegaly as well, although it's just a portable study. And here's her echo. It shows a dilated global cardiomyopathy. Here are the apical views. Maybe a little preservation of the apex, but clearly kind of a global hypokinesis. Mild to moderate mitral regurg, not too bad actually. But she is in heart failure, hypertensive, tachycardic with the history that I mentioned. I don't know if Parto's on the line, but E over E prime was 17. And I would say filling pressures are markedly elevated, even though this is only 17. The deceleration time is quite low at 140 milliseconds. We did a cath, or a cath was done elsewhere before she even came to us, and there was no significant epicardial coronary artery disease. But of course, our suspicion was, given her history of sweating, tachycardia, palpitations, the fact that she was hypertensive and in shock, was something was going on with the adrenal gland. And sure enough, there was this finding here of what is a tumor right adjacent to the adrenal gland, consistent with a pheochromocytoma. So after treatment with phenoxybenzamine, metaraxine, and propanolol, a week later, her EF is markedly improved compared to what it was at baseline. And after treatment for a week, actually the anesthesiologist wanted to wait a little bit longer even. In a week, her heart had improved, but a few weeks later, she went to the OR, and sure enough, a pheochromocytoma was diagnosed and removed. So that's an unusual cause of systolic heart failure. In my final case, this is a favorite board question in the United States. What is the most likely diagnosis in this 58-year-old man with pulmonary infiltrates and syncope? So you can see the pulmonary infiltrates here on the left. You see evidence of conduction abnormalities here, right bundle branch block, left anterior fascicular block. And then we do the echo, and here's what it shows. Especially right here. This is an apical 4-chamber view, and you can see this extensive aneurysm in the basal to mid inferior septum. So the regional abnormalities here don't fit the distribution of typical coronary artery disease. You see this kind of aneurysmal abnormality of the septum. And this is indeed cardiac sarcoidosis. It's caused by non-caseating granulomas. It can cause regional wall motion abnormalities in an unusual distribution, meaning it doesn't fit the typical coronary anatomy. It can result in heart block and sudden death. Here's a pathologic specimen showing us these non-caseating granulomas and scar. The most common location for these are actually the left ventricular free wall. But second is that interventricular septum. And it's very common to develop aneurysms in that interventricular septum. The important thing is it doesn't fit the distribution of a coronary anatomy. Now, the most common echo feature is actually nothing. Somebody could have sarcoidosis, but there will be no echo abnormalities. But you can see some things. Look for the aneurysms, look for LV dilatations, look for regional abnormalities that don't fit coronary anatomy. Mitral regurg can occur and pulmonary hypertension can occur. Here's just another example showing us that little basal septal aneurysm here and the regional abnormalities that are present here that don't quite fit coronary anatomy. Usually the diagnosis is not made by echo, but echo can be a clue to the diagnosis and cause our pulmonary doctors or internal medicine doctors to do other testing that lead to confirmation of the diagnosis. So I'll summarize with this slide here showing us the primary cardiomyopathies. There are genetic cardiomyopathies, and there's a whole list of them shown. There are mixed cardiomyopathies, and then acquired cardiomyopathies. I certainly didn't cover all of them in 20 minutes, but hopefully showed you a few unusual ones, and I thank you very much for your time and consideration.
We have one question now. What's the cause of LV dysfunction in non-compaction cardiomyopathy?
That's a good question. Is Dr. Pandian here? Because I really don't know.
Pandian?
Obviously, there's non-compaction. If they have LV dysfunction, we know that their prognosis is much, much worse. If they don't have LV dysfunction, their prognosis is better. But I honestly, I apologize, Shantanu, I don't know the cause.
Dr.
Perhaps
Pandian?
Professor Pandian does.
Thank you, Sunil. It was good series of cases which I enjoyed, as I always do. I don't know the answer for that, but I guess that there's so much less myocardium, functioning less myocardium, that might be eventually, but I don't know.
Yeah, so
that seems like a good answer to me.
So, Dr. Mankar, you mentioned about hemochromatosis and the T2 imaging. We have Dr. Nitin Burkule. Is Nitin around? I am seeing Dr. J.C. Mohan also. Can you unmute Nitin? Is he there? But I think Dr. Mohan, Dr. Nitin showed us good MRI, and he once in one of our meetings he told about the early T1 mapping in cardiac MRI for hemochromatosis. Dr. Mohan.
No, I just wanted to comment on that non-compaction part first.
Okay.
There are a couple of studies available, one from Netherlands, I think there is another from Europe, showing that non-compaction actually is characterized by what is called solid body rotation, which means you don't see you don't see the ringing or twisting motion of the left ventricle. Both apex and the base actually move in the same direction in non-compaction, even in those people who have a relatively preserved ejection fraction. It obviously means that the myofiber anatomy somehow is different in patients with non-compaction, and that could be one of the mechanisms of left ventricle systolic dysfunction.
That's an excellent point.
Yeah, we have seen actually, we ourselves actually have seen some cases, and we did present actually in Echo Nagpur sometime in the past, and these individuals have actually both apical and the basal rotation same positive direction as the counterclockwise direction. So you really get tend to get the twist which is close to zero or maybe closer to that, a few more. Yeah, the other part about hemochromatography, yeah, that's true. We had a discussion. T2 star imaging is something which Dr. Nitin Burkle did talk about. T2 star imaging is one way of quickly picking up hemochromatosis, and we now, with courtesy Dr. Nitin Burkle, are learning more and more about cardiac MRI. Thank you very much, Sunil.
Thank you so much, Dr. Sunil. Amazing talks, amazing cases. I think we move on to Partho. Is he around? I can see him. He's going to talk on constriction. Can you unmute him?
Hey, thank you very much. Wonderful to see everybody who has taught me about constriction here, actually. So Dr. Mohan and Nat actually brought me up speed with the research that subsequently happened. And the journey of constriction has continued from India, and I'm really delighted to be able to come back and summarize what we understand about constriction and differentiate it from restriction. All right, so constrictive pericarditis, to summarize very succinctly, what does it mean? It's basically a situation where you are impeding the diastolic filling. So you are both reducing the intrapericardial space and also altering the diastolic distension properties of the cardiac chamber. And there is also certain changes introduced into the deformation of how the LV relaxes. And these differences that come in together cause elevated filling pressure and lead to the syndrome of chronic constrictive pericarditis. You can also get the same features very early on with effusive constrictive pericarditis, and it can be transient in some of these patients. But the physiology is essentially due to an altered distension and diastolic restoration properties. And this whole field cannot move forward without referencing the work of Liv Hatley when she was in Mayo Clinic. And this is an animation that was subsequently developed by Dr. O and Dr. Tajik, which is even continues to be a teaching material for now. Shows the phenomenon of walling off of the cardiac physiology from the intrathoracic compartment. So there's a, number one, dissociation of intrapericardial and the intrathoracic compartment. And the second thing is the two ventricles start competing for the space that is available. So there is an increased intraventricular interdependence. And these lead to the classic two-dimensional and Doppler features that we currently appreciate in clinical practice. This animation clearly shows that you can see the inspiration causing filling of the RV, septum moves, and expiration causing more filling of the LV, the septum moves, and the velocities during the respiratory phases are exaggerated and can be evaluated at the transmitral, transtracuspid, hepatic veins, and you have the bounce of the septum that happens from respiratory cycles. So this is the pathophysiology of constriction, which we started appreciating in the echocardiography world. And the assessment of the echocardiographic principles has essentially been with the evolution of the different technologies that have come, starting from M-mode, color Doppler, pulse wave Doppler, to now speckle tracking, and each one of them assigns a characteristic pattern, and the assimilation of all this pattern together provide to get us an ability to characterize constriction. So in summary, constriction is putting together multiple small features that together define constriction or the pattern of constrictive physiology. We started off with the M mode, and work in the past showed two types of motion, abnormal motion. One is an abnormal motion that happens in the septum during each cardiac cycle because of the elevated filling pressure. You have the filling that is happening followed by a check. Just as you get a square root sign in the intra LV and RV pressure tracing, the same way the septum shows a sudden movement very early in diastole followed by a check in the motion. This movement is called as diastolic septal shudder and happens for each and every beat. There are also, in addition to that, movement of the septum back and forth during inspiration and expiration. And this is the second level of movement that happens because of the increased interventricular interdependence. And this motion actually is really well appreciated on M mode. And if you want to ask about one place where we continue to use M mode, and this is one place, that is, if you want to see high time resolution movement of the septum, M mode is very good. So this is continued to be seen and practice. Use of M mode for understanding abnormal septal motion is used even now, despite all the evolution towards 2D and 3D technologies. However, these past studies showed that abnormal septal motion can happen in other situations. You have atrial septal defect, large RV volume overload, chronic obstructive pulmonary disease, pulmonary hypertension, left bundle branch block. Post-surgery, you can have an abnormal septal motion, dysynchrony. All of these can confound your abilities to diagnose abnormal septal motion. And therefore, in isolation, it never stands out as the only way to diagnose constriction. So you want to add more parameter. And the second parameter that was added subsequently when Dr. Hadley was in Mayo Clinic was the appreciation of the changing velocities across the cardiac cycle. And you can see here the mitral inflow during inspiration. The upstroke is lowest at the starting point in inspiration, the first beat after the onset of inspiration. The E and the A waves are the lowest. And then during the expiration, it reaches a peak. So the first beat after the onset of expiration, you will see a larger E velocity. So this change that happens, and if it's more than 25%, allows you to identify the presence of increased respirophasic velocities associated with constrictive physiology. And it can be calculated, and more than 25% was what was proposed in the literature to help in diagnosing constriction. Now, constrictive physiology, because of the large respirophasic movement, closely mimics sometimes respirophasic movements that may happen with conditions like chronic obstructive pulmonary disease. In chronic obstructive pulmonary disease, because of the effort of breathing, there is a large movement and you can get a pseudo respirophasic changes. Now, to differentiate that, Dr. Seawood and Dr. Tajik looked into the superior vena cava flow, which is kind of tough, but very useful if it can be done. So the JVP in inspiration, because of the small signs, it always rises up. The intra-RV filling pressures are always high. It cannot accommodate more blood. So the respirophasic movement at the level of SVC always are markedly lower in constriction versus chronic obstructive lung disease. And that is helpful in the event you're thinking about whether that is respirophasic movement may be just related to the work of breathing. So you see the inspiration and the expiration, and the changes are not very high. The third place where we like to look into the respirophasic movement is the hepatic vein. And this is very, very, very useful. Not only you see the engorged IVC confirming elevated right heart pressures, but also you see a very characteristic motion, which continues to be a hallmark of constriction. And in fact, if it is present, you invariably are thinking about presence of constriction, and that is diastolic flow reversals. So you have the inspiration, and you see just the forward velocity. There is nothing backward. So there are no systolic reversals, there are no diastolic reversals. And you're taking a look at the EKG to understand what is systole and diastole. Versus when you come into the expiratory phase, you see here remarkable backward flow in diastole with almost cessation of any antegrade flow. This appearance of exaggerated backward flow, reverse flow in hepatic veins is a very important sign of constrictive pericarditis, constrictive physiology. However, if you just put the Doppler flows alone, it may be challenging in some situations to get the features for diagnosis of final constriction. And when studies looked into the transmitral and transtracuspid, several situations you would see not the optimal sensitivities or specificities. It was not perfect when used in isolation. And one of the reasons has been the remarkable elevations in filling pressure, the RA pressure and LA pressure that sometimes you see in constrictive pericarditis. The JVP can be so high, it can be 15 to 20 or 25 centimeters of mean RA pressure. In such situation, you may not be able to get a respirophasic because it's completely saturated. It cannot make any further changes with respirophasic cycles. For example, this patient, you have a classic pericardial calcification. You see the Y descent, you see the square root sign. This is a classic constriction. Yet in the transmitral E velocities, despite there being atrial fibrillation, despite the respiratory movement happening, you just see the E velocity is at the same spot. Almost there's not much variations. You don't see the 25% variation that you are looking for. This is because the LA pressure, the pressures is so high that it cannot make any respirophasic movement. In that situation, sometimes people have advised, well, maybe you can have a leg down or stand up position, try to reduce the preload and try to make, but those are all cumbersome. So these are the situations where Doppler may be challenging. And addition of newer parameters could be helpful. So Mario Garcia wrote a nice paper of use of tissue Doppler velocity for uncovering constriction, which was then subsequently adopted by Mayo Clinic and extensively used for new concepts. One of the concepts that was provided by Dr. O's group was that you have a very high filling pattern, a restrictive filling pattern, yet the E prime velocity or the longitudinal relaxation velocity is normal. And as a consequence, your E by E prime paradoxically, which is supposed to be high, is paradoxically reduced, and they call that as annulus paradoxus. Of course, there have been subsequent work from Cleveland Clinic that challenges this concept, but nevertheless, at least it was a unique concept that was getting placed in. Dr. Tajik subsequently, when he was in, and I was doing my fellowship, Christian Aruz and himself, they proposed a term called as annulus reversus, in which the lateral wall is more impacted and challenged in comparison to the septum, which is free to move. And as a consequence of that, the lateral wall, which normally moves a lot, would be restricted in its motion, and your E prime velocity will be reduced in comparison to the septum. So they call this term as annulus reversus. Nat and ourselves, and along with Dr. Mohan, we all looked into tissue Doppler imaging with a very close lens and found certain places where application of tissue Doppler imaging would be challenging. And this would be like when you have myocardial dysfunction because of pericardial disease, a lot of calcium at the annulus. This may be challenging to measure the E prime accurately. Nevertheless, the work, at least up till now, suggests that if you add annular velocity and combine it together with other features, it really provides you quite a bit of ability to differentiate constriction from a myocardial disease. And this study from Mayo Clinic, which is more recently done about 4 or 5 years back, say that if you combine the annular velocity, abnormal septal motion, and the hepatic vein reversals, these three features can provide you quite a bit of discrimination ability for diagnosing constrictive pericarditis when used together. We have more tools that have come subsequently. Particularly, I started focusing on using speckle tracking, deformation imaging, and that has provided some interesting insight. For example, this is a patient who has got a large fluid collection. In fact, it was looked upon as a pericardial tamponade. And the patient was rolled in for a pericardiocentesis. This is not pericardial fluid. And I saw this patient, this is pleural effusion. In fact, the pericardium is very closely adhesed, and these are all fibrinous strands on the surface of the pericardium projecting into the pleural space. So we stopped the pericardiocentesis and aimed at pleurocentesis. But more importantly, the question was, why is this patient in heart failure? And what's going on? So if you then take a look at the other technologies, you see here that the patient has an engorged IVC. The PA pressures are modestly elevated. But more importantly, look at the E prime velocity, 16. You cannot have a myocardial dysfunction with a relaxation velocity which is supranormal. So when you see a supranormal relaxation velocity, that in a phase of a right heart failure, in a congested patient, you have to think about constriction. And more, if you see it more closely, you will see that there is that shudder, septal shudder, that is also seen in the septal motion. So this patient had all the classic features of constriction, but we performed speckle tracking imaging, and you can see here the speckle tracking has been done. And what it also shows is that the longitudinal motion is preserved. The global longitudinal strain is about -20 here, which is normal, which again cannot be a myocardial disease. So this is an example where the LV is having normal muscle function in the longitudinal direction in a patient with heart failure, congested, exaggerated longitudinal motion velocities. This is a constricted pericarditis. And obviously, subsequent CT shows the diagnosis. You can see the thickened pericardium, and this is consistent with what we saw. This patient was then taken up for surgery. A similar patient, same situation, again brought in for pericardial centesis, wrongly diagnosed. And you can see this is a pleural effusion. And why is this patient in heart failure? And this patient now has myocardial motion. Looks like the wall is a little thicker. And ejection fraction looks like it's normal. Has a restrictive filling pattern. And you can see here the E prime velocities are very attenuated. And if you see the E by E prime velocities, this patient has extremely high E by E prime velocities, very high filling pressure. PA pressures are also elevated. And in this example, if you perform the speckle tracking echocardiography, you see the strains are pale in the myocardium at the base and the mid-region, and there is a cherry on top appearance. So this patient has got a myocardium which is abnormal and doesn't move longitudinally well, and has a motion which is, you can see the radial motion is preserved, but the longitudinal performance is completely attenuated with a cherry on top appearance. This is a patient with restrictive cardiomyopathy. This patient had cardiac amyloidosis, infiltrative cardiomyopathy. So this is another level of differentiation with two different types of mechanics with elevated filling pressure, where speckle tracking echocardiography is useful. Now, you know that speckle tracking has become a cornerstone for diagnosing myocardial infiltration and the myocardial fibrosis. It provides powerful information for differentiating presence of a myocardial disease. And Beyond those two, there is more emphasis also on multimodality imaging, particularly for diagnosing reversible causes. Constriction can be reversible. So if you see a patient with these features over a short period of time with an inflammatory component, it may be an transient constriction. So you need to get more information about the inflammatory nature of the disease, and LGE can provide, delayed GAD enhancement can provide from MRI information about presence of inflammation, and you can provide this patient anti-inflammatory therapy, steroids, and see if it resolves. And that is possible, and the patient may not need surgery in these situations. That's very important. For example, this patient has got a very thickened pericardium with a delayed enhanced over the surface of the anterior wall of the LV and over the RV. This patient obviously was given a trial of steroids and anti-inflammatory therapy, did not subside, and then finally, of course, underwent pericardiectomy, and this is the pericardial chunk that is liberated over the anterior wall of the RV. Constrictive pericarditis does not need to have thick pericardium like the example I showed before. It can also be thin, with a thin pericardium where just the material properties are altered. So this is another variance that you will see. It's a physiology. It's not necessarily structurally altered pericardial thickness. It may be materially altered to alter the distension of the cardiac chambers and create the same effects. And this work was again brought over to our knowledge from work from Dr. O's group at Mayo Clinic. So both CMR and echocardiography provide information which is consistent and complementary. You can also perform tissue tracking on the LV in the CMR, and it provides us the same degree of information. But these information need to be incrementally added in challenging situations like secondary constriction, for example, radiation, where you want to be doubly sure that you're not dealing with a completely challenged myocardium and the patient may not recover. Those are the more difficult situations, post-surgery and radiation, where more help is needed for deriving conclusion. And we also see some help that can come from automated techniques like machine learning, which is becoming now a buzzword. We looked at this field almost 6 or 7 years back when it was in its infancy, and in very near future, some of these technologies are going to come in place to work continuously while we acquire the images, and you will see this field evolving very rapidly, and perhaps some of these technologies will allow us to integrate complex parameters like the ones we use in constriction, restriction, differentiation, and I'll present some of this tomorrow in my talk. So to summarize, this is the guideline recommendation of how you use echo. You basically can simplify the whole process by looking into presence of a restrictive filling physiology. If there is no restrictive filling physiology, it's not restriction or constriction. If it is a restrictive filling physiology with a preserved ejection fraction and a patient who has right heart failure or congestive heart failure, look at abnormal septal motion. If abnormal septal motion is not present, then you may need more information. Why is this patient in heart failure? Consider constriction, but you may need to do cardiac catheterization, CMR, so on and so forth. If abnormal septal motion is present, look at tissue Doppler. If tissue Doppler is clearly exaggerated, it is constriction. If it is attenuated, it is myocardial disease. If it is in between, those are the most challenging cases because those are mixed disease that you sometimes see with secondary constriction like surgery and radiation, where you need to do more smaller specific insights. But more importantly, these are the cases where I would subject them to CT and CMR and cath if necessary to derive the benefit of multimodality imaging. If the time course of constriction is short, definitely think about reversible constriction before you subject that patient to surgery. It may be completely reversible with anti-inflammatory therapy. Thank you very much.
My mic on? Yeah, thank you, Partho. Very nice and comprehensive talk. I have a question from a delegate. He wants to know, in mitral in annulus reversus, is it the E prime of septal lateral which is reverses, or is it the S prime velocity?
E prime.
Perfect. Right. I think he has simplified. Dr. Mohan, your thoughts? Dr. Nat Pandian, we can unmute all of them. Yeah.
Don't expose me to Dr. Mohan and Nat. They will chew me up. They have done so much of body of work in constriction. They are far more knowledgeable in this field. My information is just complementary to all that they have taught me.
Partho, excellent lecture. I think you summed up everything which we have seen over this period of last 30 years nearly now for a long time actually. As far as constrictive pericarditis is concerned, unfortunately, we in India continue to see still large number of constrictive pericarditis. And they are all by and large tubercular or idiopathic. In these 30 years since I have been interested in constrictive pericarditis, we are still not seeing post-surgical cases. We are still not seeing many post-radiation. I'm sure they are there, but I'm not seeing them anymore. Whatever I'm seeing are all post-inflammatory. And I now tend to, my practice is a little limited now. I end up seeing about 20 cases of constrictive pericarditis every year. The features are same. The two additional things which we have found useful in addition to what you have described in great detail has been we usually find that the RV free wall strain is significantly reduced in constrictive pericarditis. And also, like annulus paradoxus, if you see the free wall strain of the septum versus lateral wall, the lateral wall has much less longitudinal strain. The rotation part, we continue to actually get involved with torsion, which you published quite some time back. And we feel that the torsional patterns are really very funny. And we have seen actually, and when last time Nat was here, one of my associates presented actually torsion characteristics of constrictive pericarditis. And we did show that there were about 4 patients out of 10 who had something like solid body rotation in constrictive pericarditis. So we continue to actually be enamored by this entity. We continue to learn, and thank you very much for taking us through the entire gamut of constrictive pericarditis. But I pointed out 3 things. The RV free wall strain we find significantly reduced, and when we in doubt, we always we look at it. LV free wall strain is usually lower than septal free wall strain significantly, and of course the torsional characteristic. Rest, I think by and large we would agree. We are now seeing good amount of reversible constriction, and although the South African described long back, and the Mayo people said 15%, we are seeing little more than that, but we are still nowhere near 50% with South African described some 30 years back. Thank you very much.
Thank you.
Hi, hello, Partho.
Yes.
That was a very nice, comprehensive review. You know, it's fun to hear that. But sometimes not all patients have many of these factors. Just last week, it so happened. Last week, a patient with a progressive right heart failure, edema, ascites, and so forth, with an echo. And the echo was done outside, but it was a difficult study nevertheless. Nothing was fitting. The only thing I saw, pericardia appeared really bright and thick, and there was a septal bounce, suggestion of a septal bounce. And then I said, instead of wasting, just get a CMR, a CT, and I prefer CMR for the number of reasons you mentioned. And they did a CT, and it's an enormous degree of calcium and thickening in the pericardium. So, clinical picture, some suggestion in the echo, even if all the features do not fit, and get a CTRM, solve the problem and strip the pericardium. But it was nice to listen to you going through all that, all the different features, and it's great. Thanks.
Partho, one last question from one of the delegates. How much should be the pericardial thickness to diagnose constriction? Any comments? Unmute. Ask to unmute.
Okay, great, thank you. So the pericardial thickness should only be done by TEE, because transthoracic pericardial thickness it's not reliable. And some work that was done, again from the Mayo Clinic, there is no such magic number, because there is also a normal pericardial thickness constriction that you can see. But on CT scan, typically if you see more than 6 or 8 millimeters of pericardial thickness, typically it is a thickened pericardium. But you have to be very appreciative of the fact that you can have a completely normal pericardium thickness, but all the physiology of constriction, then also constrictive pericarditis can be present.
Perfect. Great.
Can I ask a question?
Yeah, sure.
There was a paper from Mayo Clinic on constrictive pericarditis physiology with a normal thickness pericardium, because of the alteration in the physical properties. I don't recall there has been anybody else who has reproduced it. Do you know that kind of observation?
That's Dr. O's work, yeah, I do not know. I have not myself come across any case. Is it because I do not know? I think it's basically the centers where they get the most number of cases, and they have done this pathological studies. I personally have not come across a
numbers
case
seem to
where
be
the
too high for
pericardium.
me. I think the entity exists, but I haven't seen anybody else reproduce the data.
Yeah, you're right.
It will be nice to have some reproduction.
In fact, Nat, the problem with constriction is that there is so less information. I mean, all the work that Liv Hatley and everybody did from Mayo Clinic, those were a handful of cases. I think the whole body of literature has evolved from a very small evidence and continues to be a challenge.
And I'm sure you all will agree. Certain proportion of patients, they might have some relief of symptoms, but not complete relief of symptoms because of the epimyocardial involvement.
Yes,
right?
yes.
I just wanted to make a comment about one of the publication which came out of All India Institute of Medical Sciences, and that is the level of anti-proBNP in differentiating constrictive pericarditis from other varieties of heart failure. And the interest in this paper is, although I think is now 8 years old paper, but the anti-proBNP cutoff limit was something like 359 picogram, if I remember correctly, close to that level, anywhere 350, 360. But they had a very good area under curve. The ROC actually showed very good curve. I don't know. I would like you to comment, Partho, on this anti-proBNP and constriction, since we don't do that much because we are able to diagnose an echo quite often, and we don't see the differential point, but anti-proBNP can be a very good way for a lot of people.
Yeah, no, I think there was a JACC paper some time back. I don't remember when it was, I think in 2002 or 2003. After seeing that paper, we did look into the anti-proBNP combined along with E prime as a differentiator of constriction. And this was an AJC paper, American Journal of Cardiology paper. It did work. The challenge has been that heart failure if you want to take heart failure with preserved ejection fraction, your BNP values may not be terribly elevated. So there is a confounder there. It's a little bit of challenge. How do you, in the group where you're interested the most, there actually the BNP doesn't go up that high.
Yeah, so I actually asked you to this question because Sanjeev Shah in one of papers has shown that HFpEF as much as 29% of the then have an anti-proBNP less than 300 picogram per ml.
So how can you then?
Phenotype 1.
Absolutely right.
Yeah, so I think we have Dr. Ponde, but before that, one last question. What is the duration we should wait to rule out transient constriction?
I mean, again, there is no such magic number. You need to typically follow your, transient constriction. If you're thinking about it's an inflammatory process, give 6 weeks of anti-inflammatory therapy and then bring them back and see how if there is any regression, serial changes. There is no guideline of when you bring these people. You have to just follow them up. And if you continue to see the patient not responding, then you have gone into a chronic constrictive pericarditis, you are confirmed, then you subject the patient for surgery. But there is no need for, it is not so basically, I know that these people come very late, but there is no rush. You have to be very certain before you send these people for surgery. There is no rush. This is not an acute emergency or a subacute challenge, except where you have a situation like subacute effusive constrictive physiology, or sometimes you see with the tuberculosis and pyopericardiums, and they can be very challenging situation where sometimes you have to end up stripping the pericardium and relieving the patient. But other than those, you want the things to cool down. You don't want to have a myopericarditis and things like that confounding the situation. You want things to cool down, and then you discuss the surgeries, and we all know surgery of constriction is perhaps the most toughest surgery. It is not easy, and I've seen people make a lot of errors. Post-surgical management of constriction is one of the toughest challenge. The RV dilates, you have to put the patient on prolonged inotropic therapy. So it's not an easy decision. So you have to, and it's not a magic. I mean, we always think as if constriction is treatable, you can treat them. No, I don't think it's that easy. These are very challenging patients.
Thank you, Partho. Amazing discussion. I think we have had a phenomenal discussion over the whole one day, and we are coming to one of the most important topic by Dr. C.K. Ponde, or echo in a COVID situation. Dr. C.K. Ponde is a senior most consultant cardiologist at Hinduja, and now the president elect of IAE. Dr. C.K. Ponde, can you share your slides, please?
Yeah, thank you very much, Shantanu. I'll just share my screen. Can you see the slides?
Yeah, yes.
Can you all hear me very well?
Yeah.
Thank you. Thank you very much. And all big people in ECO are there today. But I have focused this talk, I have prepared this talk keeping physicians in mind in this crucial period that we are all going through in COVID pandemic. So how to perform an echocardiogram during COVID? The first is in our institute and everywhere. First is to establish the need or an indication for a 2D echo. Then estimate the risk to the operator and the technicians, particularly the technician and the doctor. And when we had spent almost 2 weeks when the pandemic began to train our technicians in turns how to wear the PPEs and how to protect themselves while doing the echocardiograms on COVID patients. Second is planning a study is very important, which is a thrust on the focused focus. What does this mean is very simple, is that they should be spending as less time by the patient's bedside as possible, as less time as possible. And scanning protocols should be in place. They have to report it from another side. That means they should not be doing measurements, particularly LV measurements or any measurements for that matter, there at the patient's bedside. They should quickly acquire images, move out of that place, take the machine to the patient's, the outside echo, the outside ICU. There is a room, separate room with, we have put C type of laser over there. The machine goes inside the room. The laser is on for around 6 minutes and the machine is sterilized. Clean and machine and the probes before and after the echo. If the transthoracic is not urgent, then we await the COVID results to perform the echo. The echo request must be discussed in detail with the treating consultant about what information he's expecting out of you. And there could be several reasons in a COVID patients, and I will come across, I will put in my next slides what could be the indications. The acceptable indications will change from institute to institute depending on the availability of a trained personnel, dedicated echo machine for the COVID ward and ICU. We have one, thankfully, and the attitude of the administration and the frontline COVID force in that particular institute. So many institutes have become financially crippled and they just can't buy a new echo machine dedicated to the COVID facility. Thankfully, in my institute, we could buy one in the second week of March, dedicated for the echo of the COVID ward and the COVID ICU. That machine has not moved out of that facility since then. Performance of the transthoracic echo should be limited to instances when it will definitely impact on the patient's clinical management. This is very important. In the olden times, at a drop of a hat, intensivists will ask for an echo and will run in the ICU to do that echo. Now it is no more that. Every request will run through the consultant on call before it is given okay. The CDC, Center of Disease Control, and CSI all call for all elective procedures to be postponed. That is to protect the healthcare workers, preserve the PPEs and the drugs and equipment needed to tackle the COVID surge cases. And the AAC statement also said that identify non-elective indications and defer all of them. In cases which are considered for deferral, this is very important. If I defer a case, there should be no significant risk to the patient in terms of morbidity and mortality, and the same patient should not turn in your casualty, exhausting your resources because he was denied an echocardiogram. And then you have a minimal risk echo, a moderate risk for a health worker, and a high risk. High risk should be identified first. Confirmed case of COVID, close contact with a confirmed case of COVID, a suspect COVID patient is all high risk. And here we need level 3 personal protection equipment. Level 3 personal protection equipment. Thankfully, in my institute, there has been no problem in procuring them. In the moderate risk, which most of the other patients come, you have a level 2 PPE. The other thing which I faced a challenge as a departmental section coordinator was to identify vulnerable staff members, including more than 60 years, immunocompromised, etc., from scanning the suspected or the confirmed cases of COVID. Because we have only 4 senior technicians in my department, and we need senior people to go there because they should acquire images very quickly. And to acquire images very quickly and to do dedicated measurements quickly, we need senior people. The technicians who are on the learning curve of the echo in the echo department simply cannot go there. Consider remote and off-site reporting. So what we have done is we are putting all the images on the PACS, and the PACS images are transferred to the consultant on call wherever he is, and then he can report it off-site. Always consider the contingency roster, because some people may get on quarantine and things like that, and then you will have a decrease in the staff in the department. The level 2 PPE, which is most common, you have a N95 mask, you have a visor, you have a double gloves, you have reusable gowns, you have a sleeveless plastic apron over the gown, you have a cap, and you have a shoe cover. All the ICU, the indications of transthoracic echo in Hinduja inpatient department since 22nd of March have been all ICU and dialysis unit, acute hemodynamic compromise, acute unexplained breathlessness, acute coronary syndrome, more than 2-fold elevation in the HS tropi in a single day, more than mild PE diagnosed on the CT scan of the chest done for some other reason, suspected heart failure or HEPREP or HEPEP, and systemic embolism, either peripheral or cerebral. These are the class 1 indications which we have adopted. And recently one more indication has been added. I will show you why that was for. Non-ICU patients, pre-op major non-cardiac surgery, pre-op for major cardiac surgery, ACS in an emergency room, our rapid response team page on the floors for any kind of hemodynamic or respiratory compromise on the floors. So that was the indication on the non-ICU patients. There has been myocardial injury in COVID patients, and this big study done in 17 different centers has clearly clinched that myocardial injury is very prevalent in COVID patients. And that is usually diagnosed as troponin I. Elevated troponin I causes is an indicator of high or predictive of high mortality in hospital and transfer from the COVID ward to the COVID ICUs. This study published from Wuhan in the early phase of the pandemic has clearly shown with cardiovascular disease and high troponin carries the highest mortality. Without cardiovascular disease, pre-existent cardiovascular disease and elevated troponin causes the second highest mortality. When the troponin is negative without cardiovascular disease, the mortality is pretty low. One must understand that there is a peculiar form of coagulopathy in the pathogenesis of thrombosis in COVID. And this coagulopathy is generated by the pre-existent risk factors in a given patient, like bedridden status, liver injury, sepsis, COPD, CKD, and heart failure. There are inflammatory markers like interleukin-6 and CRP. When they are elevated, they predispose to thrombosis and coagulopathy. There are pulmonary microthrombi. There is a rapid and very, very widespread endothelial damage producing intravascular coagulopathy, particularly in the lungs. And we had 3 patients in the last four months who had cerebral thrombosis and coronary thrombosis at the same index event. And there is a myocardial injury and increased cardiac biomarkers leading to venous thromboembolism, myocardial infarction or stroke, and disseminated intravascular coagulation. What is peculiar for the coagulopathy of COVID is raised D-dimer in the initial phases, but all else remains normal. And as the patient becomes worse, there is a gross increase in D-dimer. There is an increase in the PT-INR, and there's a fortuitous shortening of activated partial thromboplastin time. APTT is shortened in the severe cases of COVID. And therefore, the standard APTT cannot monitor the therapeutic effect of unfractionated heparin. The neutrophil extracellular traps is the sine qua non or the pathologic hallmark of the coagulopathy in COVID. And therefore, elevated D-dimers slowly going down is a good sign. Rising D-dimers during hospitalization is indicating a worse prognosis, and more than double increase in D-dimer in a single day is an indication for an echocardiogram and bilateral lower limb venous Doppler in my institute at the current time. Echo exams need to be planned very well because we have dedicated echo machines and we need to spend as less time. Therefore, senior sonographers should be performing an echo in the COVID facility, not the learners. We have a typical portable GE machine for the COVID facility and a handheld machine, handheld ultrasound for the cath lab. We have PPs and we have limited study to be done. So we record only 5 to 6 views, 5 cardiac cycles each. We just acquire them. We measure a quick pulmonary acceleration time, mitral E by E prime, dynamic IVC and a TAPSE, and we walk out of it within max of 10 minutes. Do not sit on the bed of the patient, for heaven's sake. All of us have a habit of sitting on the right edge or the left edge of the bed of the patient while doing an echo. Never ever do that for a COVID patient. You will expose yourself and your viral load will increase. Probe and the machine should be covered with disposable plastic. The patient must wear the mask. And this slide will tell you why. If the patient is wearing a mask and a healthy contact, patient is not wearing a mask and you are wearing the mask, risk of transmission is 70%. If both of you are wearing, the risk of transmission is 1.5%. But the patient is wearing, and even if you are not wearing, the risk of transmission is only 5%. So it is very, very, very important for the patient to wear surgical mask extremely in a good way for you to protect your exposure. The mask has to be worn properly and the scanning protocols has to be answer the clinical question only in order to remove the exposure. If the clinical question is query pulmonary embolism, it should be right ventricular centric, RV centric echo. You have to do preferable right-handed scanning. I will show you why. Only acquire images at the patient bedside, do the measurements offline. So this is the right-sided echo when you are patient. So if the patient coughs or sneezes, the entire aerosol will go away from you. If you are on the patient's left side, the aerosol will come towards you. So it's always a right-handed scanning, and we acquire the basic plaques, 3 views, maybe a 4-chamber or 2-chamber, short axis at the base and the great artery level, and subcostal for the IVC. That's it. And then we acquire only 5 measurements: mitral E by E prime, peak TR velocity if it is possible quickly, if it is not, PAT and TAPSE, and that's it. So this will, in a good hands, will take around 6 minutes. This will, in a good hands, will take around 4 minutes. So in 10 minutes, the entire echocardiogram will be over. You get this one view. You get short axis at the base of the heart and at the great artery level. Then you get a 4-chamber and a 2-chamber quickly. and walk out of that place. Then, of course, you get an IVC dynamic to know the volumic status of the patient. And that will give you, IVC will give you right heart pressure, TR. If you can have, you are lucky enough to get a good TR jet, you will have the PA systolic. If you get good enough to have the PR jet, you get a PA diastolic, and you can get a right heart hemodynamics for that particular patient. There are, of course, potentially several mechanisms of myocardial injury, but the commonest one, which I feel, is a non-cardiac, non-coronary myocardial involvement, which happens in our experiences as many as 20% of moderate and severe cases of COVID. It is only mild cases of COVID which escape myocardial involvement. Otherwise, the coronary, acute coronary syndrome is another big way of involvement of the heart. One important thing which we have seen is that there is only one case which we have seen of Takotsubo in a mild case of COVID, who was a doctor and a consultant in my own hospital. Otherwise, right ventricular enlargement and acute pulmonary hypertension is usually the end result of the lung involvement or pulmonary thromboembolism. We have seen in ventilated patients of COVID, pulmonary artery pressures of 50 to 60 almost universally. Only when they cross 60 and you have right ventricular dysfunction, then you start thinking of pulmonary embolism when the D dimer is more than 4 times the upper limit of normal. So association of COVID and cardiovascular disease is very, very rampant. In this study from New England Journal of Medicine, ST elevation in patients with COVID-19, ST elevation MI, in these patients with COVID-19 who had ST segment elevation variable at the time of presentation, there was a high prevalence of non-obstructive plaques, but they had poor prognosis. So the angiographic outcomes, as many as 40% patients with COVID-19 with ST elevation MI had no culprit lesion identifiable by coronary angiography. So they have purely thrombotic involvement of coronary arteries. And the classic hallmark of that is you have ST elevation in one arterial territory, maybe 2-3 AVF. Peculiarly, there will be no ST segment, reciprocal ST segment depression. Peculiarly, there will be no typical wall motion abnormality that accompanies a classic atherosclerotic or atherothrombotic STEMI. So you will have global LV hypokinesia, you will have inferior wall elevation, no depression. You lyse these patients, they do very well. And at the end of 3 or 4 days later, when you do their angiography, you will find recanalized vessels. So machine and ancillary cleaning is important. We in my institute are doing it with 0.5% hypochlorite after having a bad experience with sterilium, which was producing cracks at the on the surface of the probes. So outpatient department. Now outpatient, we have restricted our appointments only again via triaging the patient. Is the echo really important? Is it going to alter the patient's treatment in the next 4 weeks to come, etc.? We triage that patient and we ask for COVID swabs even for outpatients nowadays after the community transmission phase has started. Triage is existing and incoming requests are handled by medical personnel and not by clerks, not by non-medical personnel. They would not be able to understand which is an emergency echo and which can be deferred. Workflow, this is what we wear: N95, visor, cap, double gross, and a level 2 PPE. There is a plastic curtain between the patient and the operator with a slit inside, and the air condition is on the side. Air conditioning machine, which is invariably the window machines in most of the labs. In my machine, my lab, thankfully, it is the other way around, and that machine has to be on the side of the operator to direct the flow on the other side. Workflow in the examination room: cleaning the table once the patient exits the room. No relative is allowed inside the echocardiography department. The echo machine is covered with the plastic, which is then removed after every examination, and the machine is cleaned and the surfaces are cleaned with hypochlorite after every examination. So that is what the COVID echo is in pandemic, and I'm open for questions if they are from the audience. Thank you for your attention.
Ponde, for such a comprehensive talk on echo during COVID time. It is a very important thing. We do have one or two questions. What type of mask the patient should wear?
Patient should wear a triple layer surgical mask. Okay. Not a cloth mask, a triple layer surgical mask with a blue facing outside. That is also another problem. People take the blue inside. The blue part of the blue surface of the mask should be facing outside.
Okay.
Is it that they should also wear N95 mask?
Not really. No. Not really required. No, not at all.
Okay.
You have given how do you sterilize echo machine and probe before and after. But are you supposed to do it after each examination?
Absolutely, after each examination. Absolutely. In fact, that is why it was becoming very tasking for us. So finally, we got a big lamp, which is a handheld lamp with a ultraviolet type C laser. And this lamp, when we move on the machine up and down for almost 5 to 6 minutes, the entire surface is sterilized.
So, but if the machine is in the non-COVID area, are you supposed to follow the same protocol?
Yes, of course, because even, I'll tell you, people who are admitted in non-COVID facility, 10 to 15% are coming positive in the second swab.
Okay.
Yeah, so it is a very different ballgame now. We don't know whether they are coincidental positives or they have acquired the infection in the hospital. We just don't know that. Yeah. So there is nothing remained now, and non-COVID facility and a COVID facility, there is a big overlap between the two. So I think it is better to be careful on both the sides.
All right. Okay, that's great.
So I think this is a fantastic discussion. I think we can keep on going.
Yes.
There is one question. How many cases of AMI have you seen because of COVID, Dr. Ponde?
Yeah. In fact, we just submitted our data for submission for the CSI. Out of the STEMIs that we received in the last 4 months, the number of STEMIs have definitely come down. We received 31 STEMIs. Out of there, 6 were COVID positive right at the time of admission. And out of the non-STEMIs, we received 47 non-STEMIs. Out of that, 10 were COVID positive at the index swab, which is a big number according to me. And I don't know whether it is to be taken as classical STEMI with a coincidental COVID positive stab, or it is a coagulopathy of COVID which has given them an MI. I have no answer to that, really.
Yeah. Dr. Mohan, would you like to have your thoughts? Unmute.
Sir, your thoughts, sir?
Mohan sir, your opinion on this?
I think I mostly agree with what you said. Luckily for us, in the city of Delhi, the COVID cases are going down. My hospital, we allocated 100 beds for COVID patients. All 100 beds were full for most of the June and half of July. The turnaround came after the 3rd week of July. And as of now, I'm talking to you, I have 16 COVID patients in my hospital. We have a 250 bedded hospital. So our number has gone down. Our staff actually, despite all precautions you said, our staff in cath lab did get infection. But luckily, actually, recovery took place. Nobody suffered too much. And although you rightly said, we did try to actually restrict, but the physicians don't understand. A lot of people don't understand that the unnecessary or non-emergent echoes should not be done. And there have been a lot of heartburning, a lot of these questions being raised by management. When echo is being asked, you just wear the things and do it. The question is, there are only few machines, and how many times you can sterilize it and do it, and it is taxing. Nobody is giving you extra staff. People want to cut down on the staff because there is no money nowadays. So very good actually, but we are now in a better position. But so I don't know about the rest of the department actually. How I can only tell you that I did only 4 STEMI per month in last 4 months. That is 16 cases all in all. And I had none of them COVID positive.
Okay.
I did much less actually. I would only do when I'm very certain that this is atherosclerotic, this stuff.
Yes.
And anything other than that, I of course I agree. I did actually suggest some other people medical treatment. Those especially who came late, those who came after 12 hours, I said, okay, we're not going to take you to the cath lab.
Sure.
Okay, thank you so much, everyone. So myself, Dr. Sengupta and Dr. Fulwani would like to say bye for now, and we see you tomorrow at 4 p.m. again on Sunday for more topics, and it's going to be a nice session tomorrow again. Thank you so much.
See you. Bye.
Bye-bye.
You want exceptional image quality. You need to assess the function of the whole heart, not just the left side. You need easy-to-use, robust quantification tools that deliver fast and reproducible results wherever you need them. With an 8% reduction in standard exam time and 21% fewer control interactions, ultrasound can be more definitive without extending exam time. You want to assess your pulmonary hypertensive patients more robustly, with a user-friendly tool to measure right ventricular function with consistent results. EPIC CVX uses artificial intelligence to align the view, position landmarks, and detect the RV border in as little as 15 seconds, enabling everyday clinical use. You want to measure global longitudinal strain quickly, to better assess overall cardiac function of patients in an everyday setting. EPIC CVX uses advanced automation technologies to deliver one-button push robust and reproducible results, eliminating the need for user interaction and aligned with the Speckle task force. You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips.